My name is Alan Weil. I'm Editor-in-Chief of Health Affairs. Very pleased to welcome you this morning and proud to be releasing our December thematic issue on the topic of telehealth. As I get started, I want to acknowledge the financial support necessary to put together the issue and the briefing and all of what's involved in doing that from the Leona M. and Harry B. Helmsley Charitable Trust. I want to acknowledge Joe Kvedar at Partners Healthcare, who served as our theme advisor. It's a big effort to put something like this together, and we're very proud of all the work. We're proud of how the work has turned into a final product. I'm excited every time an issue comes out, but I think this one hits a particularly special spot in the health affairs world. As a journal, we cover a lot of different topics, and telehealth is one of them. And you kind of think you know about it because people have been talking about it for years, and we're investing a lot of money, and there are all these startups, and of course, this is the future of healthcare. But when you take the kind of deep look into an issue and an empirical look into an issue like we are able to do in a thematic issue, you realize how much more complex it is than you might have imagined at the outset. Not only are there the multiple dimensions, there's clinician to clinician communication, there's clinician to patient communication. There are myriad implementation issues. So as much as it might sort of intuitively make sense that we would move healthcare into the same century as banking or real estate, it just turns out it's not quite so simple. And it's important to understand not just what the barriers are, but to read examples of organizations that have overcome those barriers. Of course, we've been talking for a long time about questions of quality. Are electronic visits and electronically based communications as high quality? And it turns out that even the question of, as we're learning, that in person isn't always so high quality. And so maybe we shouldn't be just comparing electronic or telephonic with in person. And then there's questions of utilization. Sure, it's more accessible, but does that lead to utilization that's unnecessary? Does it actually drive up costs because people see virtually a clinician when in fact they should just stay home in bed and drink fluids? And then it also turns out that there are so many domains of telehealth. And some of the papers in here open my eyes to things like the use of telehealth in addressing the country's opioid crisis, or the use of telehealth in oral health, which is where there are tremendous amounts of unmet need. And all of this occurs in a policy and payment environment that providers consistently say is a barrier to moving forward with the potential of telehealth, and yet there are also examples of how folks have overcome those barriers. So when we do a thematic issue, we are able to take what on the surface looks like a single or relatively straightforward topic and pull it apart and look at it from all of those angles. And that's exactly what we've been able to do in this December issue. And it gives me great joy to be able to share that with all of you. We are today going to do our release event, as we do whenever we have a thematic issue. You'll get to hear snippets from each of the authors of papers in the issue. But before we do that, I want to turn to Mitch Krebs, Director of the Rural Healthcare Program for the Leona M. and Harry B. Helmsley Charitable Trust. He was a principal at Herd Wisdom, LLC, which is a public affairs and advocacy firm that he founded. He's been one of his roles coming, I know his old boss, South Dakota Governor Mike Rounds. I used to work for a governor as well, and he was a press secretary for Governor Rounds. Distinguished career in journalism, and now relatively new on the job. It's my pleasure to introduce to you Mitch Krebs.
Thank you very much, Alan. Good morning. The Helmsley Trust is happy to partner on this thematic health affairs issue, in a topic that is very important to our work. Telemedicine is a tool used across the programmatic areas of Helmsley, improving access to care across the Midwest, the United States, and in Israel. Telemedicine is bringing access to endocrinology specialists to individuals with complicated type 1 diabetes who live in rural and underserved urban areas through EndoEcho. We are now working to replicate that work with Project Echo in other geographic areas. We've seen how Project Echo democratizes medical specialty knowledge, and we are currently providing technical assistance to support to Project Echo to create a sustainable growth plan and help them to touch 1 billion lives by the year 2025. Through telemedicine, the Coyote Project from UC Denver is easing the transition for young adults with type 1 to adult care to improve health outcomes during this tumultuous time of change. In Israel, clinical pharmacists from the more populated center of Israel are serving the less populated areas in the south via technology and are now replicating e-pharmacy to more regions of Israel. In the upper Midwest, telemedicine has been an integral tool for Helmsley's rural healthcare program for the last 9 years. Intensive care support, emergency physicians, and critical care nurses, as well as pharmacists, are available to rural hospitals and patients in 7 states, all via technology. Recently, we spearheaded expansion of services to include 24/7 behavioral health care and are creating a behavioral fellowship to train tomorrow's psychiatrists to work in rural settings and utilize telemedicine. As a funder, we at Helmsley Trust have seen the life-saving difference telemedicine makes. Evaluation and research on our grant-funded projects indicate improved access, improved recruiting and retention of medical providers, improved satisfaction of nurses, improved quality, faster access to a physician upon arrival at a rural emergency room, decreased unnecessary transfers, and expedited transfers for more acute level of care when needed. So we look forward to learning from the research featured in this issue and from the panelists presenting today. Thank you very much for being here this morning.
Thank you so much for the welcome, and we'll move directly into the content. Let me just lay out the order of the day for those of you who are here. It's a big topic, and there are a lot of overlapping issues to consider. So in designing today, we kept our panels fairly large to cover some categories of discussion. The first panel will talk about adoption and implementation, who's using, what does it take to bring up a program in telehealth. After that, we'll move to issues around access, cost, and regulation, those that affect the adoption of telehealth. We'll take a short break, and then we'll move into evidence around quality and outcomes. So there'll be presentations in each of these areas. Our authors will present their material. I'll ask a few questions, and we'll turn to you all. The first panel is so large, I don't get a seat, so I'm going to move myself up here. And if I could get my first panelist to come up, I'll start reading names. Don't be shy. We'll be hearing from Carol Kane. Come on up, come on. No time like now. We'll be hearing from Carol Kane, Director of the Division of Economic and Health Policy Research at the American Medical Association. Jiani Yu, a PhD candidate in the Division of Health Policy and Management at the University of Minnesota. Lory Uscher-Pines, Senior Policy Researcher at the RAND Corporation. Denise Anthony, Professor of Health Management and Policy and of Sociology in the Department of Health Management and Policy at the University of Michigan School of Public Health. Dorota Kopycka-Kedzierawski, Associate Professor of Dentistry at the University of Rochester Eastman Institute for Oral Health and Deputy Director of the National Dental Practice-Based Research Network. And Claire Lin, Health Economist in the Office of Planning, Analysis, and Evaluation at HRSA, the Health Resources and Services Administration, part of the U.S. Department of Health and Human Services. So we're going to do a little musical chairs while I step away as each of you start, and I will turn first to Carol.
Good morning. When we first saw the call for abstracts for this theme issue, my coworker, Kirk Gillis, and I thought we might actually have a shot at this. At the AMA, we keep close track of all sorts of physician surveys, and we were pretty sure that there were few estimates, if any, of how many physicians were using telemedicine and what they were using it for. The only estimate we found worth citing was based on 2014 data from the American Academy of Family Physicians, and of course the survey was limited to that specialty only. So despite ongoing legislative and regulatory changes that might encourage the use of telemedicine, we found that there was almost no data on how many and which physicians were using it and what they were using it for. In terms of changes, the number of states, actually, could somebody go to the next slide, please? Oh, thank you. I got it. In terms of changes, the number of states with parity laws that require coverage for telemedicine, but not necessarily payment for it, increased from 24 to 31 states between 2015 and 2017. The Bipartisan Budget Act of 2018 expanded coverage for Medicare beneficiaries with end-stage renal disease and also relaxed some of the geographic requirements of Medicare's coverage rules for telemedicine. The final rule for the 2019 Medicare physician fee schedule also included a number of new codes for telemedicine. To address the lack of data on this topic, we used the AMA's 2016 Physician Practice Benchmark Survey to estimate how many physicians are in practices that use telemedicine and what factors are correlated with its use. This work includes the first set of nationally representative estimates of physicians' telemedicine use. With it, we hope to provide a baseline from which growth in the use of telemedicine can be measured and to gain a better understanding of the factors that inhibit or enable it. First, a little bit about the benchmark survey. It's a nationally representative survey of US-based patient care physicians. By patient care, we mean physicians that take care of patients at least 20 hours per week. We have conducted the survey at the AMA since 2012, every other year, but 2016 was the first time that we included the questions on telemedicine. In the survey, we characterized telemedicine as the use of technology as a substitute for an in-person encounter with a healthcare professional. And we asked physicians whether it was used in their practice. If it was, we asked whether it was used for 3 types of interactions with patients: diagnosing and treating patients, managing patients with chronic disease, and following up with patients, and as well as 2 types of interactions with healthcare professionals: having a specialty consultation and getting a second opinion. We also asked whether their practice used any of 3 modalities of telemedicine: video conferencing, remote patient monitoring, and store and forward of data. I want to make clear that we didn't tie the use of any of the 3 modalities to either interactions with patients or healthcare professionals. For example, if a physician reported video conferencing, it could be that she was using to see patients remotely or to consult with another physician at a remote location. As you can see, in 2016, 15% of physicians worked in practices that used telemedicine for patient interactions, and 11% in practices that used it for interactions with other healthcare professionals. I don't have it in the slide, but utilization rates for the 5 underlying functions ranged from 6.5% for getting a second opinion to 11% for diagnosing and treating patients. You can also see in the slide the utilization rates for each of the 3 telemedicine modalities. Video conferencing was reported the most often by 13% of physicians, with lower percentages for remote patient monitoring and store and forward of data. I don't think it's a surprise that video conferencing was the most often mentioned. It's the most commonly covered in state Medicaid programs and the most often referred to in state parity laws. It likely also has the most widespread applicability across specialty. I also have in the slide the specialties in which physicians were most likely to report using telemedicine. You can see that radiologists, psychiatrists, and cardiologists were relatively higher users of telemedicine for patient interactions. But, as the right side of the slide suggests, they interact with patients in different ways. Radiologists use store and forward of data to diagnose and treat patients. Psychiatrists use video conferencing for e-visits, and cardiologists use remote patient monitoring to monitor patients with chronic disease. You can also see that emergency medicine physicians, pathologists, and radiologists had the highest rates of telemedicine use for interactions with healthcare professionals. But again, the data on the right suggests that they use different modalities for those interactions. In addition to differences across specialty, we also found that the use of telemedicine varied widely across practice size. Physicians in practices with 50 or more physicians were 13 percentage points more likely to use telemedicine for patient interactions than physicians in practices with fewer than 5 physicians. And that was even after controlling for other practice and physician characteristics that might drive use. We found the same for interactions with healthcare professionals, that practice size matters, as well as for each of the 3 telemedicine modalities. We also found that telemedicine use was lower in physician-owned practices. Our data also showed that telemedicine for interactions with other healthcare professionals was higher in non-metropolitan areas, again, after controlling for other physician and practice attributes. The same was true for video conferencing. We think this is indicative of a response to a lack of access to relevant subspecialists, even in areas that are not necessarily health professional shortage areas. Our final message is that despite regulatory and legislative changes designed to encourage the use of telemedicine, the use of it is still the exception rather than the rule. In our work, we found that there was markedly lower use of telemedicine among physicians in small practices and physicians that were physician-owned. We think this is indicative of the financial barrier that telemedicine implementation poses, especially for those groups. In unpublished work with earlier years of data from the benchmark survey, we have also found that small practices lag behind in implementing electronic health records in their practice. Finally, I want to thank our 2 anonymous reviewers whose comments made the paper many times better than it was when we submitted it. Thanks to them and to the Health Affairs editorial team for accepting our work.
So I'm going to let you all come up, since we're bouncing around. Why don't you come on up, and I'm just going to move out of your way.
Okay. Hi, everyone. Thank you for joining me here today. My name is Jiani. I'm at the University of Minnesota, and today I'll be presenting some highlights from a population-level analysis of telemedicine provision using the Minnesota All-Payer Claims Database. This study was done in conjunction with my co-authors from the University of Minnesota and the Minnesota Department of Health, Pamela Mink, Peter Huckfeld, Stefan Gildemeister, and Jean Abraham. And before I begin, I'd like to first acknowledge support from the AHRQ R36 grant and the Minnesota Department of Health Health Economics program for this study. So in this study, we examined the provision of telemedicine services from 2010 to 2015 along several dimensions. We looked at insurance coverage type, provider type, and rurality of the patient's residence. Currently, little is known about the population-level patterns of telemedicine use, and we believe that Minnesota is an exemplar state to conduct this analysis for several reasons. The state has had a long history of supporting innovations in healthcare delivery and has a supportive policy environment for telemedicine. For instance, in 2015, the Minnesota Telemedicine Act was passed, which increased coverage for telemedicine services to Medicaid and commercial populations. And finally, we're interested in the capacity for telemedicine to increase access for both metropolitan and non-metropolitan populations, and Minnesota contains a diversity of both rural and urban regions. So to conduct this population-level analysis, we turn to the Minnesota All-Payer Claims Database. This database contains integrated medical claims data for about 80% of the population of the state across all payers in the state. So our first key finding from this study is the overall growth in telemedicine. We found that telemedicine visits increased from just over 11,000 visits in 2010 to over 86,000 visits in 2015, representing a growth of over 600%. It's very important to note here, however, that the baseline levels of telemedicine are very low, less than 1% of all services in any given year. What I want to highlight here first is the overall volume of telemedicine visits from 2010 to 2015. So as you can see here, there was an increase across all coverage types. We also found that the telemedicine use rate increased from around 26 users per 10,000 enrollees in 2010 all the way to 113 users per 10,000 enrollees in 2015. It's a little bit hard to see here, but this increase was primarily driven by growth in telemedicine visits from the commercially insured population and those dually eligible for Medicare and Medicaid. We then examined the types of telemedicine visits supplied and who is supplying them. So we focused on two prevalent categories of telemedicine based on how they were billed in our claims data. We defined direct-to-consumer telemedicine visits as those that were billed as patient-initiated online medical evaluations, and these are typically for primary care, non-emergent conditions. We then defined provider-initiated real-time services as those billed as real-time telemedicine visits that require live audio-visual communication between a patient and a provider or a provider and a provider. We then wanted to highlight some differences between these two types of visits. So you can see here that the overwhelming majority of DTC visits were covered by commercial payers, whereas provider-initiated real-time services were primarily covered by public insurers. The majority of these DTC visits were provided by non-physician providers. So these are nurse practitioners or physician assistants. And in contrast, the majority of those provider-initiated real-time services were provided by physicians. And in that subset of telemedicine visits that were delivered by a physician, we found that family medicine physicians delivered the majority share of DTC visits, whereas psychiatrists delivered the majority share of those provider-initiated real-time services. We then examined the distribution of telemedicine use across metropolitan and non-metropolitan areas, and we found that in metropolitan areas, which is represented by the leftmost bar in each section of this figure, about 80% of telemedicine visits were covered by commercial payers. Most of these visits were DTC services and were delivered by a non-physician provider. In contrast, in those non-metropolitan areas, we found that the majority of visits, telemedicine visits, were covered by public insurers, were provider-initiated real-time services, and were delivered by a physician. So to recap some of our key findings, we found that over our study period, telemedicine use in Minnesota experienced high growth. However, the overall rates in absolute terms do remain low. We also found that commercial plan enrollees increasingly use DTC services over the study period. These are primarily provided by non-physician providers, whereas Medicare and Medicaid enrollees were increasingly using provider-initiated real-time telemedicine services delivered by physicians. In metropolitan areas, the majority of telemedicine visits were received by commercial plan enrollees delivered by non-physician providers. And the growth of these DTC services in these regions suggests that primary care access may have been expanded in these regions. In non-metropolitan areas, we found that the majority of telemedicine visits were delivered to publicly insured individuals from physicians with a specialty in mental health. And the increase in these specialty care real-time visits suggests that in non-metropolitan areas, access to specialty care may have increased. So to wrap up, some further considerations that stem from our findings are that the patterns of telemedicine use we found are likely related to the types of telemedicine visits being covered by different payers rather than the specific clinical needs of patient populations. So for instance, we found really low DTC use amongst publicly insured enrollees. However, this patient population could benefit from increased access to those online medical evaluations. For instance, one major barrier for lower income patients receiving care is having to miss work. So this suggests that Medicaid enrollees could benefit from the convenience offered by DTC services. Okay, next, this work lays the groundwork for our current ongoing evaluation using the Minnesota APCD to examine the impact of telemedicine services on follow-up costs, utilization, and quality. Ultimately, we're interested in understanding whether telemedicine visits can be a lower cost substitute for in-person care. And finally, even though this study was done in Minnesota, we believe that this population-level analysis could be replicated using other state APCDs, so it'll be really interesting to see how these population-level estimates bear out in other states. Thank you for your time.
Hello, good morning, everyone. My name is Lory Uscher-Pines, and I'm a senior policy researcher at RAND. Today, I'm going to be presenting work led by Hayden Huskamp at Harvard on how telemedicine is being used to treat substance use disorders. So a little bit of context for this work. Approximately 21 million Americans have a substance use disorder, or SUD, as I'm going to refer to it during this talk. Yet a small minority of those actually receive treatment. In fact, only about 1 in 5. And there's several factors that contribute to this treatment gap. One important one is that there's a shortage of SUD providers, especially in rural areas. So we're talking a lot about telehealth today, an innovation in healthcare delivery. The literature on telehealth as it applies to behavioral health more broadly is very robust. There's a smaller literature on tele-SUD in particular. However, certain groups have endorsed tele-SUD as an important tool to combat the opioid epidemic. Despite that, certain regulatory barriers remain. For example, the Ryan-Haight Act of 2008 restricts prescribing of controlled substances via telemedicine. So a number of regulatory barriers that are important in this area. So we aim to inform the debates that are going on regarding tele-SUD policymaking. We used Optum Labs data warehouse claims for privately insured and Medicare Advantage enrollees. We had 3 aims. First, we wanted to describe the use of tele-SUD and see how use changed over time. Second, we wanted to compare use of tele-SUD, where there's a primary diagnosis of a substance use disorder, versus tele-mental health, where there's a primary diagnosis of a mental illness, so 2 different categories. We also wanted to discuss how tele-SUD is being used in conjunction with in-person SUD care. So we see significant growth in tele-SUD use over the study period from 2010 through 2017. About 0.65 visits per 1,000 enrollees with a SUD diagnosis to just over 3 visits per 1,000 enrollees. So although this is significant growth, there's greater growth in tele-mental health use. A few more findings. It follows here that tele-SUD made up about 1% of all telemedicine visits during the study period, and that's in contrast to tele-mental health visits, which made up 35% of all telehealth visits. Also, 81% of tele-SUD visits were delivered in outpatient settings, and about 15% of visits were for psychotherapy. A variety of clinicians delivered tele-SUD services in our sample. Just under half of services were delivered by PCPs and just under a third by psychiatrists. We compared tele-SUD users with a diagnosis of a substance use disorder with non-users with a diagnosis of a substance use disorder, and found that non-users were more likely to be users were more likely to be male, to be under age 40, to have a moderate or severe SUD diagnosis, to live in a rural area, to have a diagnosis of opioid use disorder, to have a severe mental illness, and to live in a higher income area. So long list there, some key differences. We also found that users of tele-SUD were using in-person SUD services more frequently and with greater intensity. 99% of tele-SUD users had an in-person ambulatory SUD visit during the study period versus 51% of non-users. They were also more likely to be using SUD medications. So to wrap all of this up, I want to point out that we see relatively low rates of tele-SUD use in this commercially insured population, and this may represent a missed opportunity in the context of the opioid epidemic. Also, we saw that telemedicine is primarily being used to complement in-person SUD care, rather than to bring services to new patients who may not have access. And because of that, that leads us to conclude that tele-SUD alone may not be sufficient to meet the needs of communities. Also, telemedicine is a tool, but it is not going to solve the problem of a limited supply of addiction specialists in the US, and that's something that we still need to work on. I'd like to draw attention to the fact that the SUPPORT Act was just signed into law in October, and the SUPPORT Act had a number of provisions to reduce access barriers to tele-SUD in Medicare. Beneficiaries no longer need to present at a rural healthcare setting in order to obtain tele-SUD services. So given the fact that there's a lot of attention around the tools to combat the opioid epidemic and that there's a changing policy landscape around tele-SUD, we feel that it's very important to continue to monitor trends in tele-SUD use across different payers and different populations. Thank you very much for your time.
Good morning. I'm really thrilled to be here today, to be part of this event, and to be part of the special issue from Health Affairs. I apologize for I'm losing my voice. My name is Denise Anthony. I'm from the University of Michigan, and my paper with my co-authors, Celeste Campos Castillo, who is a sociologist at the University of Wisconsin-Milwaukee, and PhD student Paulina Lim, also at the University of Wisconsin-Milwaukee, explores who is not using patient portals and why not. Patient portals are online tools that provide patients with secure internet access to their medical records, lab and test results, visit and other health information, and email communication with providers. Previous research has shown that there are real benefits to portal use, but also some concerns related to disparities and barriers to use. An important benefit of online portal use is that patients become more engaged with their health and their health care when using a portal. There's also evidence that portals help patients better adhere to their treatments. However, there are also concerns related to portals. In general, new treatments in healthcare and new technologies in general can exacerbate disparities because it typically is used by people with more resources, or those people have more access to those kind of tools. Previous research has found some evidence of disparities in portal access and use. For example, some studies have shown that older patients are less likely than younger patients to use a portal. Other research shows that racial and ethnic minorities are less likely to use. Those with lower income, those with less education, and those with public insurance are all less likely to have access to portals or to use a portal. There's also evidence of barriers to portal use. Some barriers are technological, like lack of access to internet at home. Other research has found that some patients are reluctant to use portals because they are concerned about the privacy of their information, while others say they don't want to use a portal because they're worried that it might interfere with their doctor-patient relationship. Given the evidence about real benefits for patients from portal use, but also that differential access to portals might exacerbate disparities, we set out to find out who is not using a patient portal right now and why not. Using data from a nationally representative survey of U.S. adults in 2017, we looked among insured patients who had a doctor visit in the 12 months prior to the survey. We found that 63% of insured patients reported not using a patient portal in 2017. We found that men were less likely than women to use portals, that those with less than a college education were less likely to use a portal compared to the college educated. Those with Medicaid insurance and patients without a regular provider were all less likely to use a portal. Overall, only 60% of patients say they were offered a portal by their provider or insurer. And again, similar groups, as well as some racial and ethnic minorities, were less likely to say that they had been offered a portal. About 59% of patients who were not using a portal said they were not offered one. The survey also asked respondents who said they were not using a portal about 5 possible reasons why they were not using one. Patients with Medicaid and patients with Medicare insurance were more likely to say they were not using a portal because they preferred to speak directly to their provider. Other patients said concerns about privacy and security about the portal were the reason they weren't using one. Patients older than 40 years old and some other racial and ethnic minority groups were more likely to say this. Finally, and in contrast to some previous research, technological barriers were not a significant reason for not using a portal for any group. There are some important implications of our findings. Despite significant federal incentives to providers to promote portal use to patients over the past decade or so, nearly 2/3 of patients are not using one, and 60% say they were not offered one. And even with this low level of use overall, we still see disparities in use by education, by insurance type, and to some extent by race and ethnicity. Finally, we see that some of these disadvantaged patients are concerned about their relationship with doctors, worrying they won't be able to talk to their doctor or to disrupt their relationship, and others are concerned about privacy and security. We know from other research that privacy concerns can affect patient relationships with physicians, including how they communicate and trust their doctors. So these concerns are important beyond portal use. So some recommendations based on our findings. To ensure that new tools like patient portals do not exacerbate disparities, instead of incentives to providers for getting 80% of patients to use a portal as we have now, which can end up benefiting higher resourced patients more, incentives should be targeted towards supporting disadvantaged patients specifically to access and use portals. But for patients to want to use portals, the portal tools must be secure, must be usable, and indeed useful. That means technology designers must have patient needs at the center of their design, and policymakers must set standards for security and for those systems to be both usable and secure at the same time. Also important are the recommendations to providers that their communication with patients is crucial, both for offering portals and encouraging their use, and to address patient concerns about privacy and about the concern that portals may interfere with the doctor-patient relationship. Such interventions will require recognition that providers' communication with patients takes time, an extremely scarce resource in clinical visits today. So payers need to recognize and appropriately value the time that providers need to spend with patients. Overall, it will only be through ongoing and careful monitoring of who is and is not using new technologies like portals and understanding why and why not that we can help to ensure that innovations such as patient portals do not exacerbate health disparities, but instead lead to health improvements for all.
Good morning. I'm really thrilled to be here to present teledentistry work among our medical colleagues. So thank you so much, Health Affairs, for having us. My name is Dorota Kopycka-Kedzierawski. I'm coming from University of Rochester, Eastman Institute for Oral Health. And this is a work with my colleagues, Dr. Sean McLaren and Ron Billings. And I'll present highlights of teledentistry screenings we conducted and still conducting on youngsters. So as you can see from the slide, this is not the best picture, but not the worst one. Dental, yeah, I can assure you. Dental caries is quite prevalent, and it's the most prevalent infectious disease among US children. If you look at the CDC data, it shows that about 28% of youngsters 2 to 5 years old in this country have the dental caries. And if you look at the kids who are coming from poorer families or they are minority kids, it's even worse. Unfortunately, many of those youngsters do not have any treatment, so that's the problem. So what we did years ago, I was exposed to a telemedicine program, which was conducted by our colleagues at the University of Rochester in the Department of Pediatrics. They were doing a telemedicine visit in selected daycare centers in the city of Rochester, usually in the poorest neighborhoods. And we were thinking, why we cannot do teledentistry screenings? And we did a feasibility study. We looked at the validity, reliability of it, and it worked. Kids loved it, as you see that little kid. They like to see their teeth on TV. They were very happy. Yeah. So we did not have any trouble asking them to open for us. And what we did, we screened about 500 children. We did a clinical trial. We even followed 300 kids for a year. And we were able to show that the kids who were in this teledentistry screening utilize oral health care treatment more often than the kids who are in the traditional way of screening. We thought that pictures maybe made the difference. But anyhow, what the parents also told us, that even though we were looking at kids who are 2, 3, 4, and 5 years old, half of them never had a dental visit. So that was the first encounter for them to have their screening. And unfortunately, we saw a lot of disease. About 30% of the kids had it. Some of them had really severe disease, and nothing was treated. So we were really happy to see that things were moving. As we were doing a synchronous model, then we were contacted by Finger Lakes Group, which is the rural medical and dental clinic. They do have a dentist on staff, but they could not accommodate the kids who had significant dental needs. And unfortunately, even though the referrals were written and they knew where to go, as you can see, we had about 15% compliance rate prior to establishing of this program. This program is still ongoing. And to date, we screened almost 900 children. Most of them are youngsters, younger than 6 years of age. And what we found that 95% of those kids had significant dental needs. So as you can see in the slide, about 450 kids already received care in the operating room. So we're talking about, full general anesthesia and morbidity, which is of course related to it, but we were happy to clean those kids up, and now a next step will be to see where these kids are after they are done. So we were very pleased that the compliance rate improved. 78% of those kids were treated. This is the picture of my colleague doing it, Dr. McLaren. So as you can see, it's pretty simple. We have a camera on the computer screen. We also have intraocular camera on the other end in the Finger Lakes regions of Western New York. This is a rural area. So in terms of the impact, I am really pleased that we were able to establish dental home for those kids and improved outcomes and make sure that the kids are treated. So the next step would be to integrate teledentistry with telemedicine in the mainstream and make sure that we can actually work together and help our pediatric populations in terms of their oral health. And I'm very happy to announce that we will co-host actually with the American Teledentistry Association, the first ever national teledentistry conference in June in Rochester, New York. Everyone is welcome. We have a great panelists already in place. We will have Dr. Paul Glassman, who will be heading from California. He created the virtual dental home for individuals with disabilities and people who are living in group homes. We will have insurers, lawyers, and I think also people from the community. So thank you so much for your attention. It's great to be here.
Good morning, everyone. My name is Claire Lin. I'm from Health Resources and Service Administration, HRSA. It's my greatest honor to be here today to discuss our study titled Telehealth in Health Centers, Key Adoption Factors, Barriers, and Opportunities. And this is a team project, so I would like to acknowledge all my HRSA co-authors who are all listed here. Just a little statement saying that views here are purely authors and they do not reflect any of HRSA's official policies. So I would like to first emphasize that telehealth use is important for health centers. By saying health center, I'm referring to those health centers funded through federal grants, so federal funded health centers. But I will use the term health center throughout my presentation. Just keep in mind, I'm referring to those health centers funded through HRSA. So health centers, telehealth adoption is very important for health centers because we know that health centers are community-based, patient-directed, and primary care focused. Improving access to care is always central to health centers' mission, and good news, telehealth has the potential to help in improving access to care. However, telehealth has not been fully adopted by all health centers. So we'd like to know what could possibly weigh in during this adoption process, and what are the factors, what are the barriers, and the implications. This study, we analyzed Uniform Data System, so-called UDS, in 2016. This represents nearly 1,400 health centers and serving nearly 26 million people, and this is 2016 data. Mandatory reporting for participants of HRSA's health center program, and 2016 is the first year that UDS collect information on telehealth use. Health centers were asked whether they're currently using telehealth. If yes, what is telehealth for? If no, why not? We use the mixed method approach. We use probability regression on analyzing adoption rate and the associated factors. We use a qualitative analysis to analyze the reasons and the barriers. What did we find? So overall, 38% of our health centers are currently using telehealth in 2016, with half of them using telehealth for mental health care, and slightly over a quarter using it for multiple types of services that could include mental health care, primary care, specialty care, oral health care, or managing patients with chronic conditions. Now, factors with significantly positive marginal effects are in blue, and factors with significantly negative marginal effects are in green. Let's look at the factors in blue first. So you can see, no surprise here, rural health centers are more likely to use telehealth than their urban health center partner. And this makes sense to us because it's probably reflecting a higher need to improve access to care due to workforce shortage in many rural areas. A health center, so if a health center is a patient-centered medical home, PCMH, or if a health center has any behavioral health providers on staff, it is more likely to use telehealth. And it's very likely that the telehealth is just part of the integration case. A health center in a state where Medicaid pays for live video or store and forward services is more likely to use telehealth. And I think especially the store and forward, which is only reimbursed by probably a third of the Medicaid programs across the United States. Now look at the factors in green. So we can see that percentage of homeless patients and older patients, if these percentages are higher, a health center is less likely to use telehealth. And we found similar things from our qualitative analysis. Health centers were more hesitant because they just don't think those patient groups could fit for telehealth. They don't know whether they can use telehealth for homeless patients. Finally, a little surprising here, if a health center is part of a health center control network, it is less likely to use a telehealth. So health center control networks are just group of health centers work together on the challenges and issues that they have encountered related to the use of health IT. So we think that it's possible that during this specific time period, health centers were just more focused on implementing EHR rather than telehealth, just with their very limited resources. Now talk about the barriers reported by health centers not using telehealth. You can see from this figure that cost reimbursement and technical issues are key barriers. Cost reimbursement are issues with like billing, payments, while technical issues are more like no equipment, lacking equipment, or incompatible EHR system. Rural health centers and urban health centers are sort of similar in terms of reporting those barriers. Broadband, which we always say, oh, broadband is an issue, broadband is a barrier, we separate it from the technical issue. But surprisingly, broadband was only reported by 19 health centers in this data, which is less than 5%. And this is great news. So we think that because Most of our health centers have EHR system in place as of 2016, and you know those applications need broadband, so they already have it. Our study, of course, has some limitations. We were only looking at associations, so don't infer any causality here. We don't know the actual telehealth utilization. The only thing we know was, okay, this center is using telehealth. And also, our analysis at the center level, not site level, but remember that a health center can have multiple sites. But with all the limitation, looking forward, we have several important implications that we'd like to discuss. First, the rate of adoption is expected to increase because from our qualitative analysis, we realize many health centers who are currently not using telehealth are researching, implementing telehealth. And second of all, more education will be helpful, especially for those who did not perceive a need to use telehealth. And third, if we can leverage the current existing technical assistance, again, health IT is not equal to telehealth. So if we can tailor those technical assistance for specifically telehealth use, they will be helpful. Ultimately, we hope health centers can use telehealth to improve the quality of care and then improving their care for underserved population. Thank you.
This is a situation where the sum is significantly greater than the whole is significantly greater than the sum of the parts, in that each of you have looked at a perspective on a topic, and rather than just following each thread individually, I want to step back and ask a couple of questions and sort of open it up to those of you who want to weigh in. The first one is really picking up right where Claire ended with this notion of networks. We heard from the outset that smaller practices are less likely to be using various forms of telehealth. Can we talk about the shared resources that would be helpful? I want to move beyond a general term like technical assistance. What are the shared resources that could be made available, whether it's at the doctor's office level, at the health center level, the health system level, that would accelerate the adoption of telehealth? Who wants to dig a little deeper into what the resource needs are? Someone wants to dig a little deeper into it. Claire, kick us off.
So beyond the technical assistance, because everything we provide is technical assistance, HRSA provided direct grant funding for health centers, so I can only speak for health centers. We have direct grant funding for health centers to use telehealth, and also telehealth is kind of like a allowable cost delivery model. Like if you use telehealth, you can definitely claim that as your cost. And we help for building the telehealth capacity as well. And also, our HRSA's office, Federal Office of Rural Health Policy, set up the telehealth strategy, and we have a lot of TRC Resources Center available. So those are all resources that healthcare organizations can utilize to build up the telehealth capacity.
Yeah, I want to add to it. As far as I know, in the rural healthcare center we are working with, they hire an IT person, and they had a special person who is scheduling the kids for the teledentistry visits.
Other thoughts? Yes.
I think I would just say that payer support for this kind of work is really important, and maybe promoting that is available where it is available to providers, as well as to support their interaction with patients, I think might be a necessary thing, because it's underutilized even where payment exists.
So let me use that actually to fold in a second question, is when we're thinking about payment policy, a number of you referred to places and instances where you have a change in policy, or you have a policy that says we'll pay for remote visits, and that's sort of the direct way to do this. There's a lot of talk, and of course we've published a great deal in health fairs about alternative and emerging payment models more around population health and outcome-based that are not an extension of the per visit piecework model. So I guess my question to you is, in addition to policies that are directly about paying for visits, what do we know about how using more patient outcome, population health outcome payment models affects the take-up, the interest, particularly on the provider side of making some of these investments in telemedicine? I'm patient.
So I will say part of our ongoing evaluation is to examine the impact of the Minnesota Telemedicine Act on how providers are going to be providing telemedicine for Medicaid and commercial populations. And we will be focusing on the years 2016 and 2017, so I can't quite speak to that yet, but that is part of our ongoing work.
And again, this isn't directly part of the work, but to the extent that the benefits of, say, things like portals or telehealth lead to improvement in patient health and compliance, and that payment models like ACOs, patient-centered medical homes, are paying for those kinds of outcomes, it can be tied, I think, to telehealth in that way, and in fact might spur telehealth because those outcomes might be particularly tied to these kinds of new tools, not just to patient outcomes in general.
So this suggests, that, and we'll get a little bit into this in a later panel, but this suggests an important additional angle of research. There's a lot of research on access. Does this improve the availability of services? There's a fair amount of research on the quality. Are we getting, are these visits functionally equivalent or in some instances superior in terms of the interaction? But it sounds like there's another area of inquiry, which is the further downstream patient outcomes. Does the constellation of including telemedicine in the array of services available to patients improve outcomes in a way that then creates a business model that's supportive in population-based payment structures? And because we don't have a lot of those, we don't have a lot of evidence, but we probably need to build that evidence base if we expect those alternative payment models to yield investments in telemedicine. Let me ask one more question, then I'll open to the audience. It's a little, maybe a little argumentative, but it comes slightly, Denise, out of your presentation about who's not using portals. And I guess the question is, how much should we be pushing patients to use something they say they're not ready for? And you might ask the same about clinicians. How much should, is it really a good idea to push a technology that people say it's not as good as seeing the doctor, I'm worried about privacy, or should we because it really is better for them?
I take your point, but I think that to the extent that when I first started looking at things like electronic records and patient portals, there is discussion of these kind of tools going back into the 1960s, believe it or not. And each time it is raised, providers worry about it. They say, oh, patients aren't going to like it. There are all these complications. There are all these negative potential outcomes. And patients say, oh, I don't know if I would use it. And then anytime we gather the data and look at the evidence, when it's used in ways that are really engage the patients and provide them with a real useful tool, and the same for the providers, it is better. There is an enhancement that might be the replacement for an inpatient visit or something like that might have lower cost as well as quality, or it may be a supplement to patients who can't get to a provider because they're in a rural area, or enhance a service in a way because it's more beneficial to them. So I think we don't know yet, and it doesn't mean that all patients must use these, but I think that to the extent that, for example, in this paper particularly, that so many patients were not even offered a portal, and among those who were offered, they did use them. That, I think, tells us something about that there is some benefit and potential for this that we haven't even seen yet.
Yeah,
Just to add to what Denise said, I don't know if we should be incentivizing ongoing use of these tools, but we've heard for many different telehealth interventions that there's an initial hesitation to use the service, both on the provider and patient side. And maybe we can incentivize that first-time use and then leave it up to their discretion after that on whether or not to use it for a prolonged period. But get over that initial inertia or hesitation. Sometimes all you need is just demoing a certain intervention to then buy in and want to use it long term.
That's very interesting. I have more questions, but I'm sure some of you do as well. So we have a microphone and we're on camera, so please wait for it to come to you. And
Good morning. I'm Krista Droback with the Alliance for Connected Care. This question's for Lory. We're really excited about the new reimbursement for SUD treatment in Medicare. And you said that that it's primarily used to complement SUD care. And I wondered, but it looked like your data said that there were a lot of assessments, like upfront assessments of patients. So I wondered if you could just walk through kind of how it happens.
Sure. So one thing that I didn't share is that the median number of visits, tele-SUD visits among tele-SUD users is 1. And these folks are using a lot of other in-person SUD services. So when we say that it's complementing in-person care, right now it's not bringing care to those who are not accessing SUD services at all. It's an add-on. Which doesn't mean that it's not important for patient engagement and patient outcomes, but at present, it's not being used as a substitute for in-person care. Yeah.
right here in the center.
Hi, my name is Renee Cabral-Daniels from Community Care Network of Virginia. I think you're all doing a great job and loved what you were saying. My question is for Claire Lin. I was very surprised to hear that health centers that are part of health center controlled networks are less likely. And I was thinking if you could go into that a little further, because I'm thinking a lot of primary care practices, whether they're in health centers or not, are really coming together with different hospital networks. And I was just wondering what role in particular maybe being part of a network might be in terms of making that a greater barrier. Thanks again.
Thank you. So I wouldn't call this as a barrier, just to begin with. This is just a fact that those health centers in a network, in the past years, they were very, very focused on implementing electronic health records, and that's what the whole network is about, like helping them to establish the patient portal, the EHR system. So if you imagine a health center has like just 2 people who are good at technology, or just these little resources that are technology related, they're busy with the EHR system implementation, they might just have less resources available for telehealth. So, but given that we are almost like 100% EHR adoption within health centers, we definitely expect that those health centers will be gearing towards more telehealth use in the future, because now this is what they should do next. So I wouldn't call HCCN as like barrier. We never say that. I think it's just the fact that they had different focus.
Interesting. There were 2 folks over here, and then we'll come back around. So let's start way in the corner.
Hi, Mary Lou Mayhew from MITRE Corporation. One of the things we're looking at is sort of that patient journey. And one of the underlying themes I heard all of you talk about is, some building trust maybe with the clinician. How do you think we should be doing that and integrating telehealth in that patient journey to support outcomes?
I think that's where the provider communication really helps and is necessary, even if that means then the patient switches more to using these tools. It's to assure the patient, and maybe older patients or some disadvantaged patients even more, that this will not interfere with the doctor-patient relationship. The doctor is still going to be their caregiver and involved in their care and in direct conversation if they need to, but that these kinds of tools can actually be helpful and beneficial to them, and addressing concerns around security and privacy of those issues, that acknowledging that patients might be concerned about this and talking about how the system is being implemented in a secure way in their practice or in the health center or wherever it is.
Are there a number of visits you think that they need to have first, or a period of time?
I don't know that we can say, although that they have patients who already have a provider, a regular provider, are more likely to use these tools. So not having a regular provider is a barrier, if you want to say that, is a problem.
Other thoughts on this, or we'll turn? I think there was someone else right up here. Yes.
Hi, Lance Kilpatrick. For Denise and Claire Lin, kind of building on what you just talked about, right? In your discussion, you referenced creating more incentives for the disadvantaged, to paraphrase. And clearly, health centers, the vast majority of your population would probably fall under that category. So, what are those incentives that could be created, in your opinion?
Well, one thing might be support in the practice to help communicate or demo a tool or go through how it works with patients who might need a little more time. So the less educated, those on Medicaid, older patients, some of those who are less likely or to use some of the portals or to have particular concerns, they need the doctor to reassure them or their provider to reassure them, but then they might need additional support. That's not going to come from the physician, but someone else in the practice who might be able to provide some of those educational tools that might address these concerns specifically, that might give step-by-step instructions. Those kinds of resources are probably needed within health centers, within practices, and that can be provided for as an incentive for health providers to be able to do this, for example.
I think you're right, and I would like to add to a piece of education. I think it's very important that we educate our health centers, tell them that even those patients are homeless, you can still use telehealth. Health centers were hesitant because, our patients are a lot of homeless, a lot of older, they can't use telehealth. That is not completely correct. You don't need a cell phone to use telehealth. You can come to health center, and then we can use telehealth for you to connect with a different provider. You don't need your own device, or say you don't need broadband at home. So we just need to do more education in terms of telling health centers that what you can do, how you can maximize your telehealth capacity, and how can that be helpful.
While we're here, we'll take you and get a few more in.
Just that, Chip, I'm Harry Cook, by the way. Just a follow-up question to his question. I think a lot of people might, sort of looking back at meaningful use, wish it was done differently, but it was, it might be an understatement, but it was very successful, as you sort of mentioned. The health centers have 100% EHR adoption, and it seems like you need some sort of push for providers. What efforts do you think need to go in to make sure we can incentivize telehealth without having those repeats of misaligned incentives and companies making products that their users hate?
There's a great question. Who wants to answer that?
I would add that a lot of the demand for this is going to be coming from patients, so I don't know how much we need to incentivize providers. The convenience revolution is being fueled by the fact that consumers want something more from the healthcare system than they've gotten in the past. We talked about banking and real estate, so it may be enough of a push that the patients will want this and demand it, and will shop around if they don't get it.
And I think in terms of
A little closer.
people with employer-based health insurance, which is the majority of the population. And so many employer health plans are covering different types of telehealth visits now, but often it may be not available with that person's regular primary care physician. So, maybe I want to take advantage of that with my health plan at work, but I would really rather do that, not with one of these, small companies or growing companies that offers that through employers, but rather with my personal physician. So I think the more patients see that and, again, demand that from their own home physician practice rather than just the one that's available through their health plan, I think that will also help incentivize practices to move that way.
Okay, so I'm going to take one here. There was someone in the back, and then we're probably going to be out of time, but Carol, we'll go to you.
I'm Dr. Caroline Poplin. My question is for Denise. Have you heard that the patient portals are being used a lot by the category we call the worried well? These are patients on whom we spend a lot of time and who are particularly interested in convenience, and I think the health system would be more efficient if we were able to concentrate our attention on people who have chronic illnesses or serious acute illnesses.
I can't specifically address the question. I think it's a great one, though. But to the extent that we are seeing some, what we're calling the disadvantaged populations who aren't using portals, that does suggest that to some extent it's college educated who are using portals. It is those on private insurance who are using portals. That we don't have a health measure to be able to answer that, but it is more resourced populations that are using them.
And I will say we have a paper, not exactly on worried well, but on demand coming up in the next panel. I thought I saw someone in the back, but in their absence, we'll come up here and then we'll wrap up this panel.
Thank you. Margaret Flinter from Community Health Center and the Weizmann Institute. There's a wonderful theme here of the continuum of public health, population health, and primary care, not just for underserved, but certainly including underserved. And Dorota, I was particularly interested because, of course, health centers have been so focused on oral health. Your slide and your data makes such a case for how we could really address the oral health of the population through school-based health centers, the school-based alliance across the country. And I wonder if your research, you see any indications that this is becoming part of the service delivery system, certainly as we've seen in Connecticut, but part of the service delivery system across the country to make tele-oral health a fundamental part of school health services.
I have to say that teledentistry has evolved much slower than telemedicine for different reasons which I can't explain. I can only speak for our work, and I think the numbers are really striking. What we're trying to do would be easily reproducible in any other states or any other settings. And again, I would think that your point is very well taken, because we can have a hygienist or even a telehealth person who can screen for us at schools remotely, and especially like Minnesota, Alaska, there are mid-level providers that they can do very basic dental services for the kids. But I think that would be the way to go. I agree.
Okay, as we wrap up this first panel, I'll just say, and we'll delve into these a little more as we go on. What I take away from this collection of papers is that the use of telehealth emerges from a full ecosystem that has to really run end to end. You have to have a process that's amenable to a telephonic or electronic system, which is why you have different uptake in different specialties, as we heard at the outset. We have to look at patient expectations and provider expectations and acknowledge that although things can be driven in an economy where everyone wants more now, that the drivers of that economy have different levels of resources than others who are also needing healthcare services. And so it's not just sort of accepting those expectations, it's leading those expectations. And then we need financial models that address not just the upfront investment, which is part of what's involved, but the ongoing viability of these kinds of interactions. And I'm just struck by how, at this point, I would say we have pockets of successful ecosystems where those elements are lined up, and large portions of the healthcare system where we don't have that. And so we see these growth curves, but they are not equally distributed by specialty, by geography, by almost anything you might imagine. And it takes a look at the entire end-to-end ecosystem, and then when you create that, that's when we see the adoption. So I thought this was a terrific evidence-based kickoff to our discussion. Please join me in thanking our seven opening presenters. And now I'll ask our next panelist to come up, and I will even get my seat back as we move into our next topic, which is access, cost, and regulation. I will introduce our speakers as they come to the front. We're going to hear from Daren Anderson, the director of the Weizmann Institute. I'm going to ask, I know we don't have a break here. We do have one later, but if you're taking one on your own, let's take it quietly. You don't want to miss too much of this, and I don't want to get in the way of others. Please, could we keep the noise level down, including my old panelists? Could you? So we're going to hear from Daren Anderson, director of the Weizmann Institute and vice president, chief quality officer of Community Health Center, Inc. We will hear from Sachin Shah, assistant professor in the Department of Medicine at the University of California, San Francisco. David Flannery, director of telegenetics and digital genetics in the Center for Personalized Genetic Healthcare of the Genomic Medicine Institute at the Cleveland Clinic. Jeongyoung Park, assistant professor at the George Washington University School of Nursing, and Keisuke Nakagawa, a postdoctoral scholar in the Department of Psychiatry and Behavioral Sciences at the University of California, Davis. I will come down here, and Daren, let you kick us off.
Well, thank you very much. Good morning, everybody. So my background is in primary care. I'm a general internist and have worked in health centers, federally qualified health centers, for pretty much my entire career. I'm a health services researcher and director of the Weizmann Institute. And the question that this study sought to answer really arose from the frustrations of frontline primary care providers like myself. You have a patient in front of you, you're providing good primary care, but you need a specialist. You have an EKG that you're not quite sure about. You're wondering whether you should increase the dose of the medicine that you're on, that the patient's on, or if you should add a second agent. You have a rash, you think you know what it is, but you're not quite sure. And unfortunately, these types of questions are happening more and more, and there's increasing difficulty in obtaining the answer to those questions. Studies suggest that about 25% of all visits to health centers result in a referral to a specialist, like I just described. And one of the problems is that regardless of whether your question is a relatively simple one that you could curbside, or a complicated case of end-stage renal disease with COPD and congestive heart failure, the mechanism to get the answer for that question is the same: a face-to-face referral. Because providers like me and like my colleagues no longer round in the hospital. We don't rub shoulders with our primary care colleagues. We have limited to no time in the exam room to pick up the phone and call somebody. So we send people for face-to-face visits. And that poses a challenge to the entire healthcare system, but it particularly poses a challenge to Medicaid, where issues of network adequacy are paramount, particularly in rural locations, but no different in the inner cities or in the suburbs as well. There are vanishingly fewer specialists and sources of specialty care to accommodate this increase in volume. So the results are negative. The results are longer wait times. In my health center, we had up to a 12-month wait to get a patient in to see a dermatologist. The results are high no-show rates. I don't remember what I booked 12 months ago. I doubt you would either. And also, this is posited to be a significant contributor to health disparities and health inequality. There's also a substantial cost. This increase in referrals to specialty results in increased cost to payers, and in particular to state budgets. We know that specialty care is expensive, tends to rely more on expensive tests and procedures. We know that primary care is a bargain. So the question that we sought to answer with this study was, can we do something about that? If we can improve or develop a better way of communicating specialty to primary care, back and forth, can we have an impact on the cost as it relates to specialty care that's being delivered for patients who have Medicaid? So this was a very pragmatic study. This was not a randomized controlled trial. We have done previous work at the Community Health Center and the Weitzman Institute where we did randomize and have a proof of concept that showed cost savings when you connect cardiologists with primary care providers. So for this study, really bolstered by that work, we decided to roll out e-consults, electronic communication between specialty and primary care for multiple additional specialties. And we chose our top 4, which were endocrinology, orthopedics, GI, and dermatology. Those were the 4 that were the hardest to get, the longest wait times, and the most frustration by providers like myself. And we implemented an electronic connection where providers, specialists from the University of Connecticut Health Science Center were able to electronically message back and forth using a secure HIPAA-compliant platform and exchange clinical information. The key elements were that the primary care provider, we really embedded it in their workflow so that they didn't have to think of it. They didn't have to do a lot of extra work. They didn't have to go to another website and type the question. They simply referred, and we had a referral coordination team that did most of the manual work of uploading the information and sending it to the specialist. The specialist received a question, the relevant content from the EHR, not all of it, but a picture if it was dermatology, an EKG if it was cardiology, 1, 2, sometimes 3 clinical notes from previous encounters, and then within 2 days, they would return an answer back to the primary care provider, and the first thing they would say was whether or not they felt the patient needed a face-to-face. If they did, they'd give some advice about how soon and some suggestions for what to do in the meantime. If they didn't, they would give guidance back to the primary care provider. And our question was, what are the cost implications of setting up this kind of a communication? So we got a very large Medicaid claims data file from Connecticut Medicaid that spanned the period of implementation. And we did a staggered implementation. We started with derm, went to ortho, went to endocrine, went to GI. And we studied all of the referrals to specialists for any of those 4 specialties for a 2-year period before we started doing this, and then all the way up through till the end until at least 7 months past the last specialty. So we had this sprawling data set, and we looked at the costs and compared them between patients whose initial consult was a face-to-face and compared that to patients whose initial consult was an e-consult. And we had 2 groups to compare. One of the biggest challenges was Medicaid eligibility in Connecticut. That changes month to month. We only studied patients who had continuous eligibility during that time period before and after the e-consult or the face-to-face consult. And what we found was that for each of these consult events, the period leading up to that consult, 6 months before, there were no differences in cost, in specialty-specific cost. We use a grouper so that we could actually isolate and identify specific costs related to the specialty that was being referred to. And we found no baseline differences. We also found that the 2 groups, patients who got a face-to-face versus those who got an e-consult, looked pretty much the same. There was a slight difference in the age of the 2 groups, but other than that, same sex, male, female, race, ethnicity, those sorts of things. But what we found is that in the intervening time after the consult was requested, there was a significant difference in the total specialty-specific cost for each of the specialties that we looked at. And you can see the specific differences specialty to specialty. This is expressed as an average per member per month cost over a 3 to 6 month period. Given the issues with claims lag. And the bottom line was that we saw an $84 per member per month reduction in cost in the group that got an e-consult. So our conclusions are substantial, we feel. This has many, many benefits, and cost savings is obviously one of them. There are very few interventions that have a direct, rapidly accruable cost savings to Medicaid. But it goes beyond that, because there are many costs we didn't consider. Medicaid has to pay for transportation for many of these patients. We didn't consider that. Patients have to take time off from work, often from low-wage jobs. They have to arrange childcare. They need to sometimes take buses to get to their... so there's an enormous improvement in convenience, allowing patients to get more of their care in primary care. And then lastly, this is, although not directly studied in this study, a real satisfier for primary care providers as well. It allows us to do more work in our primary care office and really help us to engage patients on a more comprehensive basis and provide them that patient-centered care that they're looking for. Thank you very much.
right, thank you. My name is Sachin Shah. I'm a physician researcher at the University of California, San Francisco. So let's start by acknowledging that there's considerable interest in virtual visits as a low-cost alternative to in-person care. This enthusiasm has been somewhat tempered by analyses, including that from MedPAC, which just this year sort of noted that telehealth services may act as a supplement to in-person services rather than a substitute, thereby increasing utilization. Work published in Health Affairs and by some of the panelists here today show that in fee-for-service, virtual visits do not appear to replace in-person care. On the other hand, ACOs have a financial interest in limiting low-value care. Okay, so in theory, ACOs should be better about using virtual visits to replace in-person visits. So the aim of this study was to answer this question: does the use of virtual visits lead to decreased use of in-person visits in an ACO? So we examined a 3-year experience of a medical practice in a large ACO. We were looking at the Partners Healthcare ACO, which is party to multiple shared savings contracts with Medicare as well as private contractors and Medicaid. They piloted virtual visits as an alternative to in-person care. The ACO reimbursed physicians at the same rate as in-person visits. Patients paid their usual copay. So the financial incentives were relatively the same between in-person and virtual visits. Here we go. Sorry. So we specifically looked at a large medical practice within the ACO, and we matched users of the virtual visit program with a comparable group of non-users. We examined the in-person visits, the rate of in-person visits following registration with the virtual visit program. So there are 2 key findings from this study. Key finding number 1, some virtual visits replaced in-person visits, but most added to in-person care. So virtual visits reduced in-person visits, but increased the total number of visits. So patients who used virtual visits had 33% fewer in-person visits. But patients who used virtual visits had 80% more total visits. That's virtual visits and in-person visits. Most virtual visits represented new utilization. We estimate that 71% of virtual visits represented new care that would not have otherwise existed. Key finding number 2, the reduction in in-person visits did not persist. So we observed an early decline in the use of in-person care that did not persist. It was transient. So I'm going to take you through a graph here. It's a little complicated, so I'm going to walk you through it. On the y-axis, we have the in-person visit rate. So the higher numbers mean patients are seen more frequently. And along the x-axis, we have time both before and after registration with the televisit program. The solid line will represent users, and the dotted line will represent non-users. So we see in the pre-period, both groups used in-person care about the same rate. Shortly after registering with the televisit program, those users of the virtual visits had a substantial decline in in-person visits. However, this effect was transient, so that by a year's time, there was no difference in the use of in-person care between users and non-users of virtual visits. This observed phenomena coincides with the concentrated use of virtual visits early after registration. Oops. So what we find here, so this is a bar graph, basically shows time after registration from Q1 through Q6, and just the total number of visits. So what you should see here is a high or heavy concentration of virtual visits right after patients registered with the program. So they registered, they used it a lot for the first quarter, and then use significantly petered out following that first quarter. So there are 2 key findings from the study of an ACO-based virtual visit program. 1, some virtual visits replaced in-person visits, but most added to in-person care. And 2, the reduction in in-person visits did not persist. There are 3 takeaways from this study. 1, these results provide ACO administrators with an estimate of the potential gains from reduced in-person visits as they try to cost out whether such a program would be viable in their care setting. 2, this study provides some support for the idea that ACOs are better about using virtual visits to replace in-person visits. And 3, virtual visits may be a viable tool for ACOs, but more work is needed to determine how virtual visits can substitute for in-person care long-term. what clinical conditions, what workflows. The on-the-ground research is still open and needs to be done. I'd like to thank my co-authors, and I'll take your questions later. Thank you.
Can you hear me okay? Is this working fine? Good. All right, I'm David Flannery, and I'm sure when I was introduced, you wonder what a geneticist is here talking about this stuff. But I have a long background in telemedicine. I started doing telemedicine in Georgia in 1995. And when I left Medical College of Georgia in 2014 for a new position, I was doing 3 half-day clinic sessions a month of telemedicine around the state. At the same time, my Twitter profile shows that I'm a telemedicine evangelist, even though I don't have the hair. I got all these other specialists at the Medical College of Georgia to start doing telemedicine as well. And so I had experience with promoting this, developing networks of care and other specialists doing this, as well as dealing with some of the regulatory aspects since I created the telemedicine credentialing policy for the hospital. And then I had the role of being on the board of several telemedicine organizations, including the Georgia statewide telemedicine organization, where we actually started dealing with growing and developing a telemedicine network, which by now has over 800 endpoints around the state of Georgia. So I'll just give you some background. I'm not just the geneticist there. So I also wanted to introduce my co-first author, Robert Jaron. Mr. Jaron is a lawyer, but don't hold that against him. He also is a policy person for Qualcomm and deals with the technology parts, especially remote patient monitoring and those things. And he really has the real policy chops in this group. All right. He has fans, I don't. Wow. Anyway, our paper took the approach, well, first of all, there's no slides. Aren't you glad to hear that? Our paper took the approach of learning from the past in order to describe approaches that would not impede progress in development and delivery of virtual and digital healthcare. And this is because we want to look forward, like the telemedicine that you're thinking about, face-to-face, direct-to-consumer or physician to patient, is just the beginning of all this. What's going on now is we have remote patient monitoring. We have chatbots developing. We'll talk about that in a little bit. We have digital therapeutics. You may not have heard about this, but it's an evolving area in digital medicine. And talk about things like clinical decision support tools in the EHR. These are new digital tools that are being developed. And then there's inevitably going to be the rise of artificial intelligence in healthcare. And we said, let's don't mess it up. We're still arguing about the definition of telehealth at a certain point in time. So what we did was we wanted to look at this and then give some advice and realize that it's important that there be developed a manner which proves that their impact on healthcare, but make sure that it's safe and effective. But we want the things to be burdensome to people. We want things to be implemented. We want patients to have access to these services. And we want to go ahead and make sure that we do this in a measured way. We pointed out in our paper that there are some encouraging signs right now that policymakers are getting it. For example, CMS and the physician fee schedule that came out broadened their coverage of telemedicine and telehealth, which was good. They surprised many of us who deal with CPT coding and that sort of stuff when they invented 2 new services. Everybody said, what is this? The patient contacting the doctor for a short check-in, and then the other one about patients sending a picture or something to their doctor. That was quite remarkable. And also one of the coverage things they expanded was covering the e-consults, and they now recognize those CPT codes and they have RVUs. Don't get too excited. It's going to be maybe 1 RVU at the top. So anyway, we think this is happening because there's a lot of things that are now promoting telemedicine and telehealth and digital medicine. And I've been saying that it's coming for since 1995, and it finally appears it is. And I think part of this is because patients are insisting on this. You think about this, many people now work remotely. They're used to using Zoom or Skype to have conferences, have their work groups, that kind of stuff. So it's not unusual in the concept of having convenient care. It's just right. And then there are actually developing literature about this in the medical literature as well as in the lay literature. And so this is expanding people's awareness of this. And we could discuss people like Eric Topol, who published books about it, and expand that kind of thing, as well as Joe Kvetter, who actually wrote a book about this as well. And then there's advocacy of professional organizations around telehealth and digital health. And it's not only like the American Telemedicine Association that was doing that for 25 years, but there's also specialty societies. The American Academy of Pediatrics has published several things about recommendations about telehealth use in pediatrics. And the American Dermatology Association and other specialty societies have done that. We also want to give a shout out, if we have that, to the AMA. The AMA started becoming proactive about this. They passed resolutions about telehealth and digital health. They passed a paper, was not quite a resolution, I'm not sure what it was described at, about the role of artificial intelligence in healthcare. And you can go look these things up on the AMA's website. And then the thing that, small disclosure, Robert, Jared, and I have to make is that they also created the Digital Medicine Payment Advisory Group, which is a multi-specialty group of people who are experts in digital medicine as well as in coverage policy, CPT coding, and is taking this on in a prospective manner. That's how we end up with the 3 remote patient monitoring codes that got approved and will be in effect January 1st, 2019, as well as the series of e-consult codes which got approved and will be published in January of 2019. So, in conclusion, I think that people are getting it, but we put in our paper some caveats about making sure that people pay attention and don't make regulation too burdensome. Thank you.
Good morning, everyone. My name is Jeongyoung Park, and I'm so thrilled to be here today to present the study on behalf of my team. And I also want to acknowledge that this study was funded by HRSA Health Workforce Research Center program. So our paper aimed at a better understanding of how state telehealth policy and also the consumers' characteristics associated with the use of telehealth services using 4 years of consumer survey data from Association of American Medical Colleges. So we first examined the trend over time by 8 different modalities. So except for the telephone communications, the telehealth use significantly increased over the period of 13 to 16. So with the new modalities such as the live video or live chatting or live texting is really gaining traction over time. And the fastest growth reported in use of live video communications rose from 6% to 21%. But the uses varied significantly by population characteristics. For example, the live use communications are most dominant among the population with high income and also have some difficulties with some physical problems or mental issues. But everybody believes that telehealth is a really important strategy for improving access to care for underserved population. However, the key underserved population, including Medicaid, low income, and rural population, still use live video communication least. But in recent years, there are a lot of federal and state level support and grant money to improve the adoption of telehealth use, especially in rural underserved area. In particular, the state have a significant control over their coverage and reimbursement for telehealth through their Medicaid program, as well as their law governing the private insurers. So we look at the role of state telehealth policies, assuming that the less restricted state telehealth policy would lead to the increase of telehealth services. So based on the 13 individual state-level coverage and the reimbursement policies, states have pure restriction on their provider type, location requirement, or scope of service cover, or they have a parity law, then state receive A or B ratings. Otherwise, if states have more restrictions or have no parity law, and they have C or D, F ratings. So a series of our analysis, however, did not support that there are a significant association between less restrictive state policy and the use of live video communications across all population level as well as among the underserved populations. Indeed, the population characteristics such as age, their health status, or their income, insurance, and rural locations really remain the biggest predictors of their use of live video communications. So given our findings, it really suggests that the state level removing restrictions may not enough to improve the telehealth utilization by consumer side. So new incentive for both providers and consumers to adopt and actually use the telehealth are needed. Perhaps removing the consumer side barriers, particularly the financial ones, may be more effective for increased telehealth use for the underserved population. Thank you.
Hi, my name is Keisuke Nakagawa, and I'm going to be talking about how policies are outdated when it comes to issues arising from retail outlets using telehealth in the context of competing in the healthcare space. And I want to first thank the Health Affairs team for considering our paper and publishing it. And I also want to thank my two co-authors, Dr. Peter Yellis and Dr. Joe Kvedar, for the tremendous guidance and mentorship in writing this paper. So how many of you were aware that Walmart is now offering free telehealth consultations by buying Airborne at their store? Yeah, so this was really fascinating. And so as part of my final experiment for this research, I decided to check this out myself. And so I actually went to a local Walmart to buy an Airborne. And so for $7, I bought an Airborne. And then within about 2 business days, I get an email that actually is a coupon code that I can use for a free telehealth consultation that's valued at about $75. So $7 for an Airborne free telehealth consultation valued at $75. And I think this is one of the best examples of how retail outlets can really offer innovative models of delivery using telehealth. So in our study, we wanted to explore the policy implications of retail outlets using telehealth. And there's 3 key takeaways. One is that the retail industry is rapidly embracing telehealth, and they're actually experimenting with really innovative ways of delivering that service. And the environment today is very ripe for retail organizations to be offering telehealth services. And the technological and business advances are far outpacing the current policies that we have in place today, like HIPAA. So, so over the course of the study, I've actually had to change this slide multiple times because there's so many market developments. Even in the last week, there's news about the CVS-Aetna merger, Wall Street Journal reporting about Amazon starting to sell software that can analyze and mine patient medical charts. And so without getting into too much detail, the point is there's clear indications by the retail outlets to be interested in more directly competing in the healthcare space and using telehealth services. So what makes telehealth compelling today? there's two key factors: access and data. So first is that there's increasing adoption of smartphones, even smart home devices. There were reports on Black Friday that Amazon's bestseller was their Alexa-powered smart home device. And so there's so many convenient ways for everyday average Americans to be accessing telehealth from their pocket, smartphones from their living rooms. But what makes this really interesting is that really telehealth hasn't changed that much over the last decade or so. I mean, as we've heard in previous talks, it's largely video conferencing, telephone. But what really makes telehealth different today from, let's say, 10 years ago, 15 years ago, is what we can do with the data. So telehealth data is quite unique because it has multiple data elements. So one is the video aspect. Next is audio components, and then we can also derive the transcription from that audio to get the text data. So these three data elements are combined into one data stream. And this can actually be quite powerful for both healthcare business and for the retail business. And retail outlets are strategically positioned to provide retail health to provide telehealth because, one, they have deep expertise in technology and the infrastructure. They also have a vast array of access points, both physical locations as well as digital. So if you think about how often does the average American visit a Walmart or Amazon.com relative to going to see their doctor, I mean, it's very different. And so retail outlets are very well positioned to be innovative in this space, but that also brings up a number of policy implications. So what are those policy implications? I'd like to briefly introduce a few of them in the paper. So the first 2 points actually deal with the convergence of healthcare data and consumer data. And so when we think about it, in more technical terms, like how do we deal with the convergence of PHI and non-PHI within a single organization? So while some of this convergence is already happening through data brokers, the precision and granularity to analyze the data is much more significant when the organization already has access to these data sources directly. And building on that point is data encryption and the use of that data. As some of you may be aware, most of telehealth is already end-to-end encrypted, which means people can't snoop in or hack into that data. But there's still policies like HIPAA that don't exclude authorized members of an organization from accessing and analyzing that patient data. So the question is, when a retail outlet has healthcare business and a retail business, should they be allowed to use encrypted healthcare data to help inform retail and other healthcare decisions? This could result in improved access to care, and it could also open up a whole new avenue of marketing to affect purchasing decisions. So bottom line, current policies and guidelines like HIPAA need to be reevaluated, reimagined, from the lens to offering appropriate guidance for organizations and the general public. And finally, with net neutrality here, this is also a very interesting topic, but since I won't have time to go much into detail here, I'm just going to mention that, and hopefully you'll read that in the paper along with other policy implications that we've detailed in the paper. And really the point is we hope that this will trigger more policy discussions and analysis. So finally, what are the key conclusions? So one is that retail outlets have unique advantages when offering telehealth. And second is that the current policies and guidelines are inadequate. They're outdated, and they need to be considering advances in technology. And finally, policies need to be proactive in addressing these potential issues while not stifling innovation, because as you can see, there is a lot of opportunity for innovative delivery of telehealth services, and we want to offer that opportunity for the industry as a whole. So there's been a tremendous amount of potential in telehealth, and with well-designed policies and guidelines that appropriately reflect the technological advances and the market developments, we can achieve more value and more access for patients, and we hope that the community will consider exploring these topics in more detail. Thank you very much.
Okay, once again, I'm going to kick off with a few questions of my own, and we'll turn not to that. Let me start, Daren, with you. We also had a paper on LA Care all using, sort of trying to overcome many of the barriers you described. And I guess a question I have, and it ripples through many papers, but it comes up in yours as well, is spread. So you mentioned this is not a standard research study. You've got something going on in your state. LA had something going on there. What are the ingredients necessary for those who look at this and say, yeah, it seems good, kind of seems good for everyone. What does it take? Where does it come from? How do we make more of this happen?
Well, it's interesting that you bring up LA and Connecticut because the answer is different in those two settings. In Connecticut, the early research that we did helped to convince Connecticut to become the only state in the country to directly pay a fee-for-service reimbursement for e-consults. And that allowed us to implement this and actually expand it. And other states are looking to follow suit, whereas in LA, it was much more of a total cost of care and an insurer that saw the opportunity to save money from the total cost of care. So I think that the short answer is a supportive payment model. Although I think adding a fee-for-service reimbursement is one way to get there more expediently in organizations that are more familiar and embraced in that model. I think ultimately, as primary care practices embrace the opportunities for advanced payment models, shared savings, those sorts of things, they will look for interventions that allow them to save money and take advantage of that savings. And I think we've squeezed a lot of the juice out of preventing 30-day readmissions. I think we've squeezed a lot of the juice out of trying to manage complex, complicated patients. I think this area of specialty care is one that we haven't looked at all that well, and so I don't think it's a surprise that organizations that are going full capitation are looking at these types of models and implementing them. So I think as we embrace new payment models, as opportunities for sharing risk really take hold, these types of models will follow.
Great. So one of the lousy things about publishing an empirical journal is that you actually get papers that say what you thought was going to work doesn't. And, it would be nice if we could just go on our beliefs all the time. Sachin and Jeongyoung, both of you have papers that sort of look at things that people say, oh, here's the answer, and well, it's maybe not quite the answer. So I'd like to dive a little bit deeper into the two of them. Sachin, I was struck, it doesn't seem surprising that you offer a new modality and you get a net increase. You didn't take away the old modality in person. You've offered something new. You wouldn't expect a one-for-one substitute. So the notion that there'd be some increase seems normal. From an accounting perspective, the question is relative costs of the two services, relative levels of substitution. But I want to pick up a theme that came up in the first panel, which is more from a health outcomes perspective. So if you're an ACO or if you're thinking the way around the kind of population health management thinking that prompts your research, how do you think about not just the financial break-even in terms of the cost of visits, but how do you think about the appropriate levels of increase in utilization so that you have some sort of a benchmark? It's not 0, it's not 100. How do you think about how much you would want utilization to go up from a clinical perspective to manage your population's health?
It's a great question. And I think it's difficult, right? Which is why we present, in the paper, we present the numbers so that a reader, an ACO administrator on the other end could do the math in their head about how much it costs to deliver a virtual visit versus the overhead and fixed costs of delivering in-person care. I'll say that my experience talking to some ACO administrators is really that they are laser focused on cost. Right? While we think of ACOs as a value proposition, both improving outcomes and lowering costs, most ACO administrators are laser focused on utilization and on cost. And so, and I think, that this is, while it would be nice to show that, with a little increased utilization also comes improved value or improved outcomes, in an APM model, I'm not sure that is going to catalyze, I'm not sure that people are going to be running to their practice managers to say, we need to adopt this right away. So unfortunately, I think it is really a dollar and cents decision. I do think that there is a sort of second tack here that's important. It's going to be a slower growing movement, which is around going use case by use case to show really demonstrated improvement in outcomes. So I'll say that, for example, in the ACO that we studied, the ALS group, which is a devastating neurologic disease, results in patients being homebound, is a phenomenal use case for telehealth. An extremely small percentage of all patients in the US, but for those patients, a really life-saving technology. I wouldn't say life-saving, but really improves the quality of life, prevents them from having to go to the emergency department. So I'd say that that's sort of a harder way to build a movement, but that is one of the avenues that's going to need to be pursued.
That's very interesting, and it follows up very much from the first panel, that this is a microsystem. It's not, telehealth is not one thing. It's very interesting. Jeongyoung, you also gave us an example. People think, oh, well, restrictive policies are the barrier, eliminate them, and we solve the problem. It doesn't look that way. When I think about the characteristics that do show up as making a difference, most of them are immutable. They're, the age of the patients, we're not going to change that. Are there other areas based on the work you did that you think are potential areas that are amenable to change that could yield increased use?
Yeah, definitely we cannot change their age, but the important characteristic we found related to the telehealth use is really their income level and also insurance and their rural locations. So I know there are really mixed results and there is no one conclusion, but we all know that the financial barriers is the most cited one. So removing the financial barriers such as waiving some co-payment, similar to we've seen in VA system, or some waiving the purchase of the equipment or buying data plan will be a really effective way to improve the telehealth, especially for a targeted populations, such as underserved populations.
Very good. David, as I was listening to you, and then it really came home in Keisuke's presentation, you talked about leadership in organized medicine, and then you talked about demand from the patient side. But one thing that's missing, as I look from the patient side, is the kind of institutional organizational infrastructure. You mentioned AMA and other organizations. How much are we getting patient input into the regime of the future other than just, I'm a consumer, I want to see a doctor now, so I pick up my phone?
I can only speak from my personal perspective. Cleveland Clinic is a patient-focused organization, and so we have the patient at the center of making all these decisions, and so they're incorporated into what's going on. But more generally, talk about implementation, just to mention another AMA initiative, they have put out a, what do they call it, Robert? It's a digital medicine toolkit or something like that just came out. I can't remember the exact name, but you can send me an email later and I can get you to that. And
Carol probably knows. Playbook, it sounds like.
Playbook, there you go, okay. So we have that, and then you have guidelines from different specialty organizations about how to implement and use telemedicine. So you have many of those things there. In the pediatric one, I believe there was patient input to that, and some of the others may have had that as well. But you're correct. I mean, patients don't necessarily always know what they want as part of what you're saying, and what they may think they want may not necessarily be the best way to do something, so I can understand that.
Keisuke, you raised some really interesting points, and I know you can't get inside the head of all these large organizations that are moving into this space, but I was thinking as you spoke, and I loved your giving us your personal experience with Walmart. You mentioned data, but I'm wondering how much we really know about what the agenda is of the retailers. When you describe your experience, I could imagine a number of possibilities. One is most people probably don't come in and just buy one thing. And when you go to the pharmacist and they say it'll take 10 minutes, that's 10 minutes to go look around and shop. So one possibility is that the hook of a telemedicine visit is to get you in to buy more things. Another is it's relationship building. We want you to think of Walmart as a health source, and so it's not just what you buy, it's the interaction. And then, of course, there's the data and the use of data in all kinds of ways that I can only imagine. I just wonder, in your looking at the various retail contexts in which you see this growth, do you have a sense of which of those dominate, or is it really just sort of a mystery? Or am I missing another? Is there another possibility?
Describe my entire research process here. I think one of the challenges of this research is we didn't want to speculate on anything, so we really stayed with analyzing concrete factual developments, and so it is still a mystery in terms of what is actually going to happen with these opportunities. But I think what's clear, though, is that we are already seeing signs from multiple retail outlets that they can do a lot with telehealth. And so I think that we need to be cognizant of when you say data, the hardest part about policy is we've done a fair bit of work on the payment side, but keeping up with or anticipating technological advancements, or even how the businesses would potentially use these types of data or retail and healthcare spaces in one physical location. I think those are the kinds of things that it's very difficult to know what's going to happen. But yet we still want to make sure that policies are well designed to guide those developments rather than completely being unaware or unprepared to address some of those issues.
Great. Okay, let's get some of your questions. I'm going to try to get new people, so I don't know how good my memory is, but I'm sure I haven't called on the gentleman right here or the one behind him, so let's start here.
Hello, I'm Akash Goyal. I'm a family medicine resident. I have a question. So how often do you feel comfortable giving a diagnosis or medication if you haven't examined the patient yourself or got a set of vitals?
Starting with that, I think the answer is a substantial number of times. Our data suggests that if we screen out referrals that are clearly for a procedure, a colonoscopy, a fine needle aspirate, upwards of 75% of the time I can get from a primary care provider who's done a good physical exam and asked a question and given me some clinical information. The specialist is able to answer their question to both parties' level of comfort. So just as a ballpark, in adult medicine, about 75% of the non-procedural consults that we do in the specialties that I shared can be effectively handled electronically. And in pediatrics, we have some emerging experience. It's about 50% as well. So, and that's not to say that the physical exam isn't important, but to get an answer for a question from a specialist, it often isn't, because sometimes that question is very specific. And the other sort of sub-point within that is if it's dermatology, a good basic camera image, a couple of angles, is often more than enough to diagnose molluscum or eczema or things like that. So I think it's more often than we expected when we started doing this, and more often than most people expect when we start doing it at scale.
I'll say from the video conferencing perspective that we were examining in specialty care, the physicians who helped to guide the policy in the program they decided together that they would not do any initial consultations via video, that patients had to do initial visits in person, and then they would have the option of doing follow-up visits via video.
Well, I would differ with that. I think you can do very adequate physical exams with peripherals, et cetera, doing live video telemedicine. And you just have to use judgment. And what I always told my doctors, every specialist who was doing it, is that the prime directive was that the care had to be equivalent to what you would do in person. And if at any point in the process of doing the consult you discovered it was not going to be quality care, you had an obligation to stop the consult and explain why, and then schedule a very rapid in-person evaluation.
And we have a couple of papers that look at quality comparisons coming up later. Gentleman right here.
Excuse me. Hi, I'm Matt Quinn. I'm the Senior Advisor for Health Technology at HRSA, and I had a thought about the retail side of it. The emergence of e-commerce hasn't necessarily resulted in a smaller credit card bill every month, maybe fewer visits to Target, and a lot of boxes by the door, but the combination is larger, which I think is the point of the retailers doing that. For Dr. Anderson, really fascinating. And Connecticut is a unique situation with paying for e-consults. One of the challenges that we found for health centers in doing telehealth is finding specialists who would work with them, especially across multiple specialties. In our paper, we show that most of them are doing behavioral health or primary care, but not a whole bunch of different services, even if they have the equipment. How did you reach out to the specialists and recruit them? Second, do you think that those e-consult relationships will translate into full-blown, live video or store and forward specialist work? And
let's keep it to two.
That's it.
Those are great questions, and we've grappled with them extensively. So there's a couple of different answers to that. The meta answer is there are a large and growing number of specialists who want to do this kind of work. They want to sit on their couch or their boat or wherever it is and answer consults. And you can do them. You can do a lot of them in the course of an hour. So for a variety of different motivations, we are not having trouble finding specialists that want to do this. The challenge relates to state. So I was surprised at your findings because state licensure and regulatory laws have a huge impact on this. There are practices in certain states that allow cross-state e-consultation, clinician to clinician. There's others that don't. So those people that I have been able to recruit in Texas who want to support a health center in Connecticut, great, because Connecticut allows that, others don't. And I think that's the biggest thing. But the other thing that we don't often think about, specialists don't particularly like to see easy consults that don't really require much of their time or expertise, consults that they could have answered with a quick telephone call. So our first, we went to the University of Connecticut, which is the state-funded hospital system in the state of Connecticut. They loved the idea of being able to do e-consults and free up access for the people who really needed to be seen. So generally when we started, we first looked to the specialist in the neighborhood or in the region with that value proposition, and then spread farther, far and wide to find other things. I mean, we don't have data yet on our pain and opioid consultations. We had to go to Arizona to find a pain specialist to do that, and we're now using a specialist in Arizona to answer pain and opioid consultations in Connecticut. But there is a surprising number of people who react to one or the other of those two sort of value propositions, either reducing their exposure to low acuity consults or just the fun and interest of doing something different in a different setting.
So I'm going to take the person right behind Krista and then the gentleman in the back, and then we're probably going to be at our break.
Hello, I'm Marion Grant. I'm a palliative care policy consultant. And palliative care is having good experience with using telehealth as avoiding emergency situations. That if a person can call and talk to a provider or share information somehow, that they can be kept out of the ER. No one has mentioned that yet, and I just wondered, I know that there must be other evidence. What can you say about that in these other specialty situations?
I have to say, in at the ACO we were looking at, the telehealth program was open to all medical and surgical subspecialists. Palliative care did not participate. I will say that the oncologists are moving some of their nurse triage to video, but that's a burgeoning area, and I think that's a clear use case where no one really wants that outcome. The patient doesn't want to be in the ED, nor does their physician, and so I think that's a clear use case. I think the question really comes down to workflow, though, right? So, how does the practice bill for that nurse's time, the physician's time? Do they do that on site where the overhead costs are high, or do they have a dedicated off-site or someone in their office doing these video visits? And I think the payment models, not from the payer, but within the institution, from the practice administrators to the physicians and nurses, has still not been ironed out.
The gentleman in the very back here.
Hi, thank you. My name's Stephen Keeler. I'm a virtual care management software vendor, so a little self-serving, of course, this question, but would like to get some folks understanding. You've kind of touched on it, but the whole point I thought of telehealth in combination with remote patient monitoring was to be able to detect earlier which provides both a lower cost for that earlier detection, but then also with that earlier detection, you can have more options to intervene, perhaps at lower cost intervention workflows. And didn't hear anybody really kind of anticipate what the convergence of that would be. So I'd love to hear, in the ACO or Cleveland Clinic, how any results coming out from the combination of the data with the increased communications capability.
I have just anecdote. I don't have hard evidence to answer your question. I have anecdotal evidence and some published literature, which tends to suggest, especially for the remote patient monitoring, that there are, in the trajectory of a patient's illness and recovery, there are peaks and valleys, there are ebbs and flows. And if many of these changes in health status tend to resolve on their own, and if we are now creating a flag every time there is a small change in health status, that the physician or the nurse on the other end doesn't quite know what to make of it, and will often send the patient to be evaluated in person, either at the clinic or in the emergency department. So at least the early evidence suggests that in many cases, these technologies lead to increased utilization. That doesn't mean that there isn't the right use case, the right training, the right expertise that develops over time to understand a true signal from a false positive. But I don't know that, I haven't seen any evidence convincingly showing that those kind of use cases.
So artificial intelligence would be the answer for that, yes.
We do have a paper on remote patient monitoring and how it affects utilization in this issue. It's just not up here on this panel. So, please join me in thanking these presenters. We have a lot more to cover that really looks at many of these questions around quality and outcomes, but let's give ourselves a 10-plus minute break, and we'll reconvene looking at the evidence on quality and outcomes.
Thank you.
I think at our next briefing, we won't actually do any real presentations. We'll just have everyone up and do hand gesticulation. Okay, if I could have my two presenters. The reason we broke this last segment into two is that we have a lot of evidence to present around quality and outcomes and utilization. But we have two papers in particular that are review papers that are not their own analysis of an individual situation, and we thought it would be good to kick this off with some more of a review perspective before we move into the papers that look at specific interventions. We'll hear from Erin Shigekawa, a consultant at John Snow Incorporated. I have to say, formerly a staff member of the organization with my favorite acronym, which is CHBRP, the California Health Benefits Review Program. I'm on the National Advisory Committee, so I say CHBRP every chance I get. And Renee Pekmezaris, Vice President of Community Health and Health Services Research at Northwell Health and Associate Professor of Population Health at the Hofstra Northwell School of Medicine. So as I say, we're going to get two presentations that are review papers, and then we'll go directly into the independent empirical papers. I'll turn it first to Erin.
Good morning. Thank you to Health Affairs for having me, and thank you to you all for being here. And I'd also like to acknowledge and thank my co-authors, Dylan Roby, who's in the room, Margaret Fix, Garen Corbett, and Janet Kaufman. Before I begin, I'd like to illustrate some context with two key points. The first is that clearly there's a changing environment for telehealth. There's changing policy, regulation, and technology, and that's part of what we've talked about today. And the second key point is that it's very difficult to make any blanket statements about the efficacy of telehealth. It really varies, as it can be used for many different patient populations, many different conditions, and with many different telehealth modalities. So with this context in mind, we set out to complete a rapid review, and a rapid review takes the steps of a systematic review and streamlines them. So it's very useful for fields that are dynamic and changing quickly, such as telehealth, where decision makers need evidence on a faster timeline. although it's not as rigorous as a systematic review, so it may not uncover all the nuances that a systematic review would uncover. So we set out with 2 key questions. The first key question is, are telehealth services considered equivalent to in-person services in terms of outcomes? And the second is, do telehealth services impact the use of other services, such as in-person visits or hospitalizations? Oops. So all in all, we returned, I think I skipped. So we looked at systematic reviews from January 2004 to May of 2018 for any patient population receiving an intervention via select telehealth modalities, including live video, store and forward, email, text, chat, and phone with a provider. And we were interested in interaction directly between a patient and a provider. So we did exclude provider-to-provider consultation, and we also excluded remote patient monitoring. The comparison groups of interest for us were in-person treatment or usual care, and the outcomes of interest were health outcomes like depressive symptoms and utilization outcomes like emergency use or hospitalizations. Our search returned, ultimately we included 20 systematic reviews in our review, and we divided them up by clinical area where possible. So telemental health, telerehabilitation, teledermatology, teleconsultation, and 3 that fell into an other category. And in the interest of time, I won't go through all of our findings, but I'll just highlight some of the most interesting. So for telemental health, we found that studies consistently supported that telemental health and in-person services had equivalent outcomes. And this includes things like telepsychiatry, telepsychotherapy, et cetera. However, there were some differences based on patient characterizations. For instance, one study by Brearley et al. Found that video assessment, there were differences if patients were older than 75, or if they had a poorer internet connection, which makes sense. And reaffirms the importance of patient characteristics when rolling out telehealth interventions. For telerehabilitation, this includes things like telerehab following a major surgery, like a joint replacement surgery or a heart surgery. And for telerehabilitation, studies also supported consistency in outcomes between telehealth and in-person treatment. And as you can imagine, for someone who has just undergone a major surgery, having a telehealth option may be very convenient to a patient. So overall, for many different studied conditions, the evidence does support that telehealth is a useful alternative to in-person care and does support equivalence in outcomes for some studied conditions. For question 2 regarding utilization, there was a lot less evidence. Fewer systematic reviews looked at telehealth's impact on utilization, and those that did tended to report mixed outcomes. So we're really not sure. We're not sure if telehealth is providing services that patients were previously going without, if telehealth is being provided in addition to in-person services, or if telehealth is replacing in-person services. The evidence at this point is inconclusive, and we're unable to draw a conclusion. So again, key takeaways. The first is that for question 1, for many studied conditions, the evidence does support telehealth as a useful alternative with equivalence in outcomes to in-person care. And the second is that there's less evidence or mixed results about the impact of telehealth on utilization, and this remains an area for more research. I'll close with a couple looking forward points, and the first is that it's very difficult, as we've talked about in previous panels, to tell the difference between duplicate or necessary services. An increase in utilization is not necessarily a bad thing if patients are receiving services that they need, particularly services they were going without before. But there are differing schools of thought about whether telehealth is meant to complement or supplement in-person services. So this is something that future research will need to look at, and also future research may look at utilization by use case. The second point I'd like to make is that we looked at comparison groups that were in treatment, in-person treatment, but in the real world, the comparison group may be a patient choosing to delay or forego care. So that's an important consideration for policymakers, whether they're comparing to in-person treatment or delayed or foregone care. And that's especially important for patients who have access issues, like trouble taking time off of work or transportation barriers. And lastly, there are real-world provider supply issues that were outside of the scope of our review, but as evidenced, there's a lot of interest in telemental health, but a lot of states are currently facing or anticipating a shortage of mental health providers. So even if we have the technology in place, if we don't have the providers in place, clearly there's still a major issue. So with that, I'll close, and thank you very much for your attention.
Good morning. I'm a health services researcher studying chronic care management interventions at Northwell Health in New York, in the New York metro area. My research team has been conducting home telemonitoring trials over the past 12 years across multiple settings and populations. Looking at the heart failure literature, over 1,200 studies have explored the impact of home telemonitoring on hospital utilization, costs, and quality of life. The results have been astonishingly varied, with some studies finding benefit while others have not. The meta-analysis I'll be presenting examined 26 randomized controlled trials using vital signs monitoring of almost 5,000 heart failure patients. The purpose of this review was to use the PICO framework to systematically combine data from different studies to try to understand some of the reasons for the great discrepancies in the literature. What you're looking at here is the typical cycle of care that heart failure patients experience in the US today. The patient starts out stable at home, seeing their doctor every few months as outpatients until they start to exacerbate. They may have edema, trouble breathing, call their doctor, and their doctor says, go to the emergency room. Sometimes they're stabilized in the ED. More often, they're admitted to the hospital for a few days and are discharged to home care. In home care, a nurse comes to check on their care and their vital signs every few days. Then they're released from home care and are on their own. And unless they happen to exacerbate when they're in that doctor's visit, the cycle begins again. When I first started studying this technology, the idea was that if a provider regularly monitors vital signs, weight, blood pressure, pulse, while the patient is at home, you can identify and treat the exacerbation at home and thereby avoid the hospitalization. That makes sense, except the data doesn't bear this out. As I mentioned before, the results are contradictory, and my team at Northwell has found the same thing. Over the past 12 years, we've led a number of telemonitoring studies for heart failure patients in the home care setting, in the outpatient setting, following patients for 30 days, for 90 days, for 180 days, following patients that are primarily white, older, well-insured patients, and exclusively enrolling younger disparity populations. Conducting these studies across these different settings, populations, timeframes, prompted our study team to conduct this meta-analysis in the context of the PICO framework, exploring variation in populations, interventions, comparators, outcomes, and timeframe. First, we looked at hospital utilization. 7 studies reported all-cause hospitalization at 180 days. And by the way, all-cause hospitalization is the most commonly explored outcome. We see on the left a graphic representation of the data. The farther to the left, the more the study's data supports home telemonitoring in this case. Home telemonitoring did not have a significant impact on the odds of all-cause hospitalization in heart failure. 5 studies reported heart failure-related hospitalization at 180 days. And although it looks better than all-cause, home telemonitoring did not have a significant impact on the odds of heart failure-related hospitalization at 180 days. 3 studies reported ED utilization, and we found that home telemonitoring interventions were actually associated with a significant increase in the odds of ED utilization. Then we looked at mortality. We find here in the top figure that home telemonitoring is significantly associated with a 40% decrease in the risk of all-cause mortality at 180 days. In the second figure, we see that this decrease in mortality is even more pronounced when looking at heart failure-related mortality at 180 days. Home telemonitoring interventions were associated with a 61% decrease, 61% decrease in the risk of heart failure-related mortality. Interestingly, this effect on mortality did not persist at 1 year of monitoring. As you can see in the bottom figure, the 6 studies that looked at mortality at 365 days found that home telemonitoring was not associated with a decrease in all-cause mortality. So there's some kind of waning effect of telemonitoring, similar to a cumulative dosage effect in drug trials. Whether it's just that people decrease engagement in monitoring after a year, or their disease severity increases such that monitoring doesn't help much anymore, we can't answer that question from the data. But I can tell you that many previously conducted meta-analyses have combined studies across multiple time periods, and that aggregating time periods makes the effect of masks the effect of the intervention. So how is it that home telemonitoring is associated with increased emergency department use, has no impact on inpatient utilization, yet appears to significantly decrease mortality, at least for 180 days? One logical explanation is that the technology does exactly what it is built to do: identify exacerbation early, thereby sending the patients who require immediate attention to the ED early, while treating patients at home for pre-exacerbatum symptoms early. Either way, prompt recognition of the exacerbation results in decreased mortality. So besides looking at the timing of home telemonitoring, we also attempted to look at the setting in which home telemonitoring is delivered. One thing we've learned over the years is that when you randomize patients at hospital discharge, most patients will receive home care, live nursing care delivered at home. Either way, whether the patient is randomized to home care or to home telemonitoring, their vital signs are being monitored. So you're not likely to see a telemonitoring effect during the first 30 to 60-day period of home care just after hospitalization, when both comparators are receiving monitoring. But what about when patients are discharged from home care and we randomize them as outpatients, when the control group is no longer being continuously monitored, except for that quarterly outpatient visit? Does home telemonitoring make a difference here? To answer this question, we conducted a moderator analysis to see whether provision of home care has a moderating effect on telemonitoring. Here, we compare those studies that were conducted in the home care setting to those in the outpatient setting. And while we see a favorable outpatient trend, there is no significant difference between the home care and outpatient setting on hospitalization. But unfortunately, our power analysis found that there were not enough studies, sadly, clearly defining what the setting was, home care or outpatient. So this is something that future studies really need to address. In conclusion, we find no evidence that home telemonitoring reduces all-cause or heart failure-related hospitalization, an increase in ED utilization in over 180 days, and significant reductions in mortality, especially heart failure-related mortality at 180 days, but that this effect declines over a 1-year period. We strongly recommend that future primary studies, as well as meta-analyses, pay attention to the PICO framework and carefully report populations, intervention characteristics, comparator groups, outcomes, and timing of interventions, as we may be aggregating these interventions far too simplistically and missing their real potential. Thank you.
I want to ask a couple of quick follow-up questions, and actually I hadn't thought of this. It does bridge the two of you. Erin, you made a very important point toward the end about comparison groups, and I just wonder if you could spend a little bit more time on that, because you didn't spend much in your original presentation, because we don't give you much time. It seems very important to understand when you're thinking about the effects of a new technology, what it means to not have access to that. So I wonder if you could just, first of all, expand a little bit on the notion of what it means to be in usual care or in a non-intervention group, and particularly since you did this review of studies, is there consistency, is there inconsistency in the studies and how they think about what the comparison group is?
Great. So studies usually think of the comparison group as treatment received face-to-face in person, and that's what they refer to as usual care. And I think there are two major important points here. One is that we've talked today about how telehealth has great potential, but it also has the potential to exacerbate existing disparities with patient populations who may have trouble accessing telehealth, with patients who are older, who may be less comfortable with technology, with patients of color, patients of lower income. All of these are things that policymakers and clinicians should really consider heavily. And then I think another important point that I didn't have time to get to is that some of the studies that we were looking at, for an example, we're looking at in-clinic dermatology versus telehealth dermatology, both provided by a dermatologist. But in real-world settings, you might have in-clinic dermatology provided by a PCP versus telehealth dermatology. And the studies that we looked at didn't tend to look at a PCP providing a service versus a specialist providing that service via telehealth. So I think those are two important considerations.
Great, thank you. Renee, you walk us very nicely through the logic of what can and can't be learned. When I think of meta-analysis, I think of drawing conclusions. In some respects, it seems like you used it to build a new hypothesis. Mm-hmm. And so my question to you would be, you mentioned the importance of additional studies. Do you feel like those would help answer the direct question of whether or not the hypothesis about the evolving patterns of care is true? Is that, how would we actually come to understand whether the logical path that you lay out is what's happening with the data?
So I think the reason we need more studies is simply because we don't have enough studies that have adequately defined whether or not the comparator or the control group is receiving home care. Because I think it really makes a difference. I think whether you are randomizing patients in the inpatient setting to the home care setting, or you're randomizing patients as they come off of home care into the outpatient setting, there's the difference. That's the rub.
And you think, I don't mean this sounds just with that, but that's sort of the key differentiator that's missing in the current literature.
I believe so.
Helpful. Any additional questions from you all? These are. Yes, we'll take you here in the back. Terrific.
Good afternoon, Augustine with CareClicks. Question for you, Renee. I do apologize if you mentioned this in the beginning of your dissertation. Is what type of devices were used in that home health care study? How much training was involved with those patients? And how often was the data transmitted to the provider in regards for them to say this is an emergency event or need to go to the emergency room?
So because this is a meta-analysis and it combines different studies, we had to use some requirements for study inclusion. And the only requirement we use is that the technology utilized vital signs monitoring and transmission. So blood pressure, weight, that kind of thing.
And I saw someone further. There we go, right in the back.
Thanks. Roxanne from the American Dental Association. Erin, I was interested in your point about patients who are older than 75 or who don't know how to use the technology or don't have internet access are not using this in the right way and they're not having the same results. I think CMS is moving more and more towards covering telemedicine for those patients. So how can we make sure that they're getting the training necessary? And did any of your studies look at that?
So to clarify, that point about patients over 75 was from one systematic review on video assessment for mental health treatment. So just emphasizing again that when we speak about telehealth, it's so important to not make blanket statements and understand that the nuances are different by clinical area and by application. But I think that to support patients who perhaps may have more trouble using telehealth, it makes a lot of sense that they would have this relationship with an established provider. So for example, once they've had a relationship with a provider and have seen them in person, then making sure that they have the capacity or the desire to receive a telehealth service. And I think whether or not, as we've discussed in earlier panels, it's not something that needs to be forced onto patients. If patients prefer in person, then I think that's also, totally fine and understandable. But I think just making sure that patients feel comfortable or have the support of somebody who may be able to help them use the technology.
So we'll take one last question over here.
Mary Jean Schumann, GW School of Nursing. So particularly, Erin, with regard to your analysis, I remember you said you looked at literature from 2004 to 2018. Did you break up any of that by time? And so I think about what's gone on in terms of technology, particularly in this area, whether it's remote monitoring or how comfortable people have gotten with the use of technology, including those of us who might be a little older, over that 14-year period. So I wondered if you had done any analysis that broke apart any of that, or if the fact that we're talking about a 14-year span hides some of the differences.
So most of the studies that we looked at, I think 14 out of 20 were from 2016 to 2018. So they're all relatively recent. So I think that addresses part of your question. And I think in the past 2 years, the trend that we noticed in the studies that were returned was that there's so much interest in telemental health and telerehabilitation, especially within the last 2 years. But I think the fact that most of the studies are from the past 2 years kind of addresses your question about use of technology.
Great. Thanks to you both. Please join me. So I know we're getting, your stomachs may be starting to rumble, but we have some really terrific papers here that tell a lot about what has been on the minds of many of you in your questions, which is what are the outcomes, what's the quality of care provided. As I invite my last panelist to come up, if you happen to be Mary Love Mayhew, we have your phone at the desk outside. But please, my final panelists, if you could join me up here, I'll introduce you as you come up. We're going to hear from Lory Maddox, Clinical Manager for Intermountain Connect Pro, which is a division of Intermountain Healthcare. Lory is also a PhD candidate at the College of Nursing at the University of Utah. We'll hear from Dana Sachs, emergency physician at the Kaiser Permanente Oakland Medical Center. Donglan Zhang, assistant professor in health policy and management at the University of Georgia College of Public Health. Kristin Ray, assistant professor of pediatrics at the University of Pittsburgh School of Medicine and a practicing general pediatrician at the Children's Hospital of Pittsburgh Primary Care Center. Marty Player, associate professor in the Department of Family Medicine at the Medical University of South Carolina. So we have 5 papers, all that look very directly at the question of what are the outcomes associated with the use of telehealth services, and I'll turn first to Lory.
Thank you so much for inviting us. And I will say that the first author here is home expecting his first baby who's due today. So they decided to send a grandma instead to talk about our newborn program. So one of the things I will say at the onset, if a newborn needs to be transferred to a higher level of care, we will do that. However, what we have learned is that not all newborns, some newborns can be managed in their local birthing hospitals, which we want. And so you may ask why telehealth is used in newborn critical care. I will say this is one of the first of the big 4 telehealth investments made by Intermountain Healthcare. It included adult critical care, crisis care, stroke, as well as our newborn critical care program. We cover a wide geography. We still have frontier communities. I have some hospitals that are over 200 miles away from their tertiary care facilities, and our great snow sometimes makes the valleys incapable of transporting newborns. So we do have our newborn critical care program. Despite the best care possible, the American Academy of Pediatrics tells us that 1% to 2% of babies will need some form of extensive resuscitation. And so I have hospitals with only 100 births a year. So this represents a high-risk, low-frequency event for many of these facilities. Telehealth is a safety net. Newborn resuscitation programs are only required every 2 years, so skills deteriorate over time. So this is here's Dr. Mitten in one of our first cases where we were evaluating our telehealth program. So it's pretty easy. If you need a neonatologist, you call him. And we try to model this just like we would do in our tertiary care centers with neos on site. If you would call a neonatologist there, you get the neo on the line. We really want them to get there as early as possible when maternal fetal risk factors are identified. And part of this is getting there early is also reinforcing the skills for the bedside team and prepping them. We've seen other research has demonstrated improved quality of resuscitations. This particular study is on reducing avoidable transfers. So we did have a staggered implementation approach. This went over, we had a staggered implementation approach, and we looked at 2 different outcomes, facility and individual analysis for our study. This included 8 hospitals in our early implementation of this program. And you can see our results on the right side is the before and after telehealth implementation. The solid line shows the average predicted number of transfers per facility per month. And you see a break, that is our 6-month, what we call the peri-implementation period, to then allow for adoption of the technology and hardening of the workflows. The difference, the drop between the threshold of the 2 solid lines is the estimated impact of our program. What you will see at the facility level in 1 year with these 8 hospitals, we estimated a reduction of 67 transports, and these are transport babies that could be managed at home, and this represents about $1.2 million to the system in not transporting the babies. Also, at the individual level, we saw almost a 30% decrease in the probability of being transferred, and this is meaningful because our current transfer rate is under 2.2%, about 1.93. So what does this mean for our organization? It really means that we're able to keep mothers, babies, and families home with their existing support system. It keeps revenue in the community and really builds the safety and the awareness of managing these patients in their community. We also, I will say another important piece is our NICUs and our high acuity beds, and this keeps those high acuity beds that we have to have for our smallest, sickest patient. That keeps them available for that. We also, I will say that this potential impact is greater. This was only 8 hospitals where our utilization was at 1%. When you think of the babies that may require resuscitation, we would like to see that closer to 3% to really capture all the babies that need a neonatal specialist. And then finally, I think this is nothing new when we think of policy. It's pretty complex right now. I will say that Intermountain has invested in telehealth to support safety, quality, increase access, avoid cost, and promote value in their communities. I have very passionate providers. I guarantee you give them the tools, you make reimbursement easy, you make legislation, licensing easy, and these people want to use it. I truly, within our organization, I don't have enough bandwidth in terms of personnel to really support all the initiatives that our program Intermountain wants to support, our consumers and our providers are asking for. So, and thank you.
Hi, everyone. I'm Dana Sachs. I'm a emergency physician with the Permanente Medical Group. I work in Oakland, California, and want to thank Health Affairs for inviting us to present today. So just a little bit of context. We know that the volume of emergency department visits has continued to increase over the past several years, and that leads to overcrowding, which has significant negative impacts on patient quality. Among emergency department visits, chest pain is the second leading reason that patients come to the emergency department, and that chest pain ED visits represent about $5 billion of the $80 billion spent each year on emergency department care. And we also know that among malpractice claims for emergency physicians, chest pain or missed MI, heart attack is one of the top reasons. So we know that timely, appropriate evaluations of patient with chest pain is critical because a delayed diagnosis can have devastating consequences. We wanted to look at use of telehealth for a potentially emergent complaint. And so our study is called A Comparison of Teletriage for Patients with Chest Pain by Physicians versus Nurses in an Integrated Delivery System. So just a little bit of background, Kaiser Permanente Northern California has over 4 million members, care across 21 medical centers. And there is a shared comprehensive electronic health record across all patients and providers that contains inpatient and outpatient care, radiology, laboratory, and pharmacy data. The Kaiser Permanente Northern California Appointment and Advice Call Center is a service available to all members. It's run by nurses and emergency physicians. And the typical protocol is that any patient can call in anytime. It's open 24 hours a day, 7 days a week. And they initially speak to a telephone service representative, and if they have any active medical complaint, then they're forwarded directly to speak with a nurse. And then the nurses follow very scripted protocols of asking questions about the complaint, and then if they have any urgent or emergent complaints, that triggers them to speak directly with the emergency physician that is working. Around late 2012, in order to try to identify patients that might need care faster, and identify patients that might need to go to the ER, they changed the protocol such that patients that called in with chest pain were forwarded directly to a physician instead of going through the nurse first. This happened, it was supposed to happen all the time, but it only happened if there was a less than 1 minute wait to speak to a physician. So if there was more than 1 minute wait because the physician was helping with another call, then the call went to the nurse. And so we did an analysis of a natural experiment, basically of call time-based routing of calls. And we looked at nurse-directed versus physician-directed calls, specifically for cardiac chest pain. So here's some of our key findings. So the graph on the left, overall, this program led to very low emergency department referral rate. So both nurses and physicians had low referral rates. Physicians had a significantly lower rate. They only sent about 10% of patients calling in with chest pain to the emergency department, compared to nurses who sent about 16% of patients to the emergency department. Overwhelmingly, the patients followed the recommendation of the provider. So it was a little bit higher for physicians. So among physician-directed calls, 86% of patients followed their recommendation and 82% for nurses. And also overall, this was very safe, which I think was a big question. And we found that the overall 7 and 30-day mortality rates was very low, was less than 0.2%, and there was no significant difference between nurse-directed and physician-directed calls. The physician calls tended to be briefer, 8 minutes compared to 13 minutes. And then we did a very, we wanted to translate our findings to potential cost savings by having a physician upfront. And so we used standard costs. So we looked at average emergency department costs, average salaries for nurses and emergency physicians. And So for every 100 calls for chest pain, having a physician up front would lead to about a $5,000 savings. And in our study, we had about 30,000 chest pain calls over the study period over 1 year. That led to about a $2 million, it could contribute to about a $2 million cost savings by having physicians answer the calls. So in conclusion, we think that a telephone triage system can be very effective and safe for managing high-risk emergent complaints, and that both physician and nurse-directed calls are very effective in doing this. We think that having a physician answer these calls for high-risk emergent complaints probably added some efficiency, which may lead to a cost savings because of fewer emergency department referrals. And we also think that having access, real-time access, both nurses and physicians have access to the electronic health record, as well as having high access to same-day or next-day outpatient care likely contributes to the success of the program. But we also think as interoperability of electronic health record system improve across systems, other systems may be able to move in this direction. Thank you very much.
Hello, everyone. My name is Donglan Zhang. I'm an assistant professor in health policy and management at University of Georgia. And I'm honored to be here and to present our study and represent our research team. And so I want to acknowledge the co-authors. Co-authors are from CDC, Centers for Disease Control and Prevention, and from Medical College of Georgia, Augusta University, and also from Texas A&M University. So in the title, we say expansion of telestroke services improve quality of care provided in super rural areas. So first of all, what is super rural areas, right? And so CMS define fee schedule based on rurality of the region. So super rural areas are the most rural places or the counties that have the vast majority of rural population. So stroke is a leading cause of long-term disability. And stroke mortality also is one of the major causes of death that has contributed to the widening rural-urban gap in life expectancy during the past several decades. Telestroke is a telemedicine technology used in stroke care, and it uses a two-way video conferencing technology to connect stroke specialists in large stroke center with physicians and patients in lower resource facilities, including rural hospitals. And our study has two objectives. First of all, we describe the current utilization or the trend in the recent use of telestroke care at the patient level. So this study is at the patient level, it's not at the hospital level. And secondly, we assess association between receiving telestroke services and the quality of care indicators and medical expenditures among Medicare beneficiaries living in rural, urban, and super rural areas. And we use propensity score matching. So we compare patients and receiving telestroke care and patients receiving usual care. The data were from CMS. We use CMS inpatient claims and outpatient claims in the emergency department from January 2008 to September 2015. The reason we did not use data after September 2015 is because there's a transition from ICD-9 code to ICD-10. And in the cross-sectional data sets, we identify patients with primary diagnosis of acute ischemic stroke, which is the most common type of stroke. And we also identify 1,663 patients who received documented telestroke services. So this is our main finding. So first of all, during the study period, telestroke services saw increase in telestroke utilization. It increased from 0.4 per 1,000 patients in 2008 to 3.8 per 1,000 patients in 2015. And it increased much faster in rural and super rural regions. And we expect telestroke utilization will continue to increase following the Chronic Care Act of 2017, which included the Furthering Access to Stroke Telemedicine Act. And Medicare will remove rural limits and expand coverage for hospitals to provide telestroke services starting in 2021. So the other major finding is we found telestroke services is associated with improved quality of care. It's associated with increased IV TPA treatment, which is a hemodialysis drug used for acute stroke care. And it increased faster in urban regions than in rural regions. And it also is associated with increased use of mechanical thrombectomy, okay, a procedure used for stroke care. And in super rural regions, telestroke services is significantly associated with a reduction in 30-day all-cause mortality, which is a huge finding here. And but total medical expenditure for telestroke care is also much, about $3,000 higher than patients receiving in-person usual care. But this is not a comprehensive economic evaluation. So our next step is we want to include cost savings associated with reduction in mortality and morbidity, and also assess the impact of telestroke services on reducing health disparity between rural and urban America. The key policy implication from our study is why telestroke use has increased. It appears that there are likely additional opportunities for even greater use. And this study suggests that by improving access to these services, the provision of important hemodialytic therapy can be increased. Continued barriers to and the successful strategies for implementing telestroke services need to be assessed as telestroke use increased to overcome the variation across states and help address disparities in stroke-related care and health outcomes. And furthermore, additional studies need to be conducted to inform how best to structure telestroke networks to support improved outcomes for patients, appropriately reimburse both the spoke and hub hospitals for services they provide, and ensure that appropriate post-acute care is provided to patients to maximize their recovery, regardless of the location of their residence. Okay, thank you for your time.
Good afternoon. Thank you all for the chance to be part of this event and the chance to speak to you about our work today on behalf of my co-authors. We have discussed many different models of telemedicine today, and so I'd like to focus us in on what I'll be talking about for the next 5 minutes, which is direct-to-consumer telemedicine, which we've defined in this study as real-time, on-demand visits with remote physicians who are employed by national commercial companies, where the patient requests a visit on demand and completes the visit through their personal telephone or computer. As we've seen in recent studies, as well as studies presented here today, there's been rapid growth in the use of telemedicine for primary care, and that appears to be driven largely by the use of direct-to-consumer telemedicine visits. One of the largest cluster of reasons for direct-to-consumer telemedicine visits is acute respiratory infections, and so that includes visits that may benefit from antibiotics, such as strep throat, ear infections, sinusitis, as well as visits that likely won't benefit from antibiotics, such as the common cold and bronchitis. There have been some prior studies looking at quality of care during visits by direct-to-consumer telemedicine for acute respiratory infections that have raised some concerns about quality, but those studies were largely very small in sample size and restricted to specific geographic areas. So the study question in our study today is, currently, in the current environment, given this uptick in use of direct-to-consumer telemedicine, what is the quality of care when adults seek care for acute respiratory infections during direct-to-consumer telemedicine visits? To answer this question, we used claims from 2015 to 2016 for adults aged 18 to 64 from a large commercial health plan with a national presence. We identified visits for acute respiratory infections, and then identified within those visits that were to direct-to-consumer telemedicine. We then matched these visits to visits that had similar patient and visit characteristics that were also for acute respiratory infections at physicians' offices or at urgent care centers. And in the end, we ended up with 38,000 direct-to-consumer telemedicine visits for acute respiratory infections that were matched with good balance to 942,000 medical office visits, or some of these slides will refer to them as primary care provider visits, and 186 urgent care visits. Within these matched set of visits, we then looked at outcomes, or at measures of quality, which included 3 different measures of antibiotic use that I'll show on the next slide, as well as among visits where the diagnosis of streptococcal pharyngitis was made, what % of those visits had streptococcal testing. And finally, among this matched set of visits, what were follow-up visit rates like? This slide shows our results for antibiotic management. There are 3 different measures on this slide. But first, to orient you, the y-axis here is the % of visits. The dark red is direct-to-consumer telemedicine. The medium red is primary care or medical office visits. And the lighter pink is urgent care visits. The first set of columns shows the percentage of visits at each of these settings that had, acute respiratory infection visits at each of these settings that had any use of antibiotics. The second set shows the % of visits at each of these settings that had broad-spectrum antibiotic use. And finally, the percentage of visits that had guideline concordant antibiotic management. And what that means is that we looked at the diagnosis that was given in that visit, and then whether the treatment that the patient received was concordant with guidelines. So if the patient was diagnosed with streptococcal pharyngitis, did they receive one of the recommended antibiotics for that? If they were diagnosed with a common cold, did they appropriately not receive antibiotics? Our takeaway from this slide and these results, which was somewhat surprising to us, is that these results were very similar across each of these settings. The difference in each of these measures for direct-to-consumer telemedicine compared to the other 2 settings was within 1 to 4 percentage points. And so given large differences in these models of care and large concerns from different organizations, these were relatively small differences. Turning to our other outcomes, we looked at streptococcal testing, and we did see a dramatic difference there. So among visits where the diagnosis of streptococcal pharyngitis was made, 1% of direct-to-consumer telemedicine visits had evidence of testing for streptococcal pharyngitis, compared to 2/3 of primary care visits and over 3/4 of urgent care visits. When we looked at follow-up visit rates within 2 days and 21 days, we looked specifically at, did the patient, after that first visit, have another visit for an acute respiratory infection diagnosis? And we found that while follow-up visits were overall not very common, they occurred with a higher frequency for patients who originally presented to direct-to-consumer telemedicine. So overall, our results showed that antibiotic management was actually surprisingly similar during acute respiratory infections for adults aged 18 to 64. Notably, there was, across all settings, their guideline concordance was hovering around 60%. So there is room for each setting to improve in their antibiotic management, but there wasn't a dramatic difference across settings. We also observed less streptococcal testing and higher follow-up visit rates. And so I think that suggests some specific opportunities for improvement in quality of care during direct-to-consumer telemedicine, specifically better integration of testing into direct-to-consumer telemedicine care, as well as a need for protocols and policies that focus telemedicine use on complaints and conditions and diagnoses where telemedicine can best replicate in-person standards of care. And if that can't be done, converting to an in-person visit. And finally, I think our results indicate the value of ongoing monitoring of quality and value as telemedicine continues to expand. As we've seen today, there are broadening or ever-changing technology, ever-changing applications, and ever-changing populations using telemedicine. And so I think it's important to remember to look at potential benefits and harms as these models of care continue to scale. Thank you.
You've made it to the last one, so thank you for staying. You won't regret it. Maybe. I'm Marty Player. I'm a family physician at MUSC in Charleston. I want to thank my colleagues, in particular Jasmine Pinckney and Dr. Vanessa Diaz in the Department of Family Medicine. Dr. Diaz says that someone has to take my photograph so I can prove that I was here and not just touring around DC. So I will, in this study, look at a smaller scale than what Dr. Ray just presented, and it's institution-specific. So at MUSC, we started a direct-to-consumer asynchronous e-visit program in 2015 for acute conditions. And we were tasked with evaluating the program and looking at quality assessment of this program. So we undertook a retrospective review of the first 18 months of the asynchronous e-visit program. The e-visits are available to adults 18 and over who are patients in the MUSC system within the past 3 years and who have access to the patient portal, in our case, which is MyChart. And we had three aims. We wanted to look at unresolved e-visit encounters, so those that could not be completed by the provider, and then also for those that were completed, if there was any sort of follow-up that occurred after the e-visit. And then we looked at some patient satisfaction outcomes that we did by survey. So in this time period, we had 1,565 e-visits, and as you can see, most were female, 80%. More than half of them were in the younger age group of 18 to 45, very small percentage there of 65 and older. And then most were in non-rural areas, 94%. And so when we were thinking, are we having a lot of visits that could not be completed in our program? This sort of, I think, gets to the question that the family medicine resident asked earlier. If you don't have a physical exam, can you do the visit? So we looked at what we called unresolved e-visits, and those were e-visits that the patient completed the questionnaire, it went to the provider, and then the provider, for some reason, said, I can't do this e-visit, you need to come in or call or something like that. So of the 1,500, we had a small percentage that could not be completed, 100 of them, about 6.4%. And then we looked at the reasons that were documented, if any, for why those could not be completed. And you can see that most of them, 90% of those that were not completed, was concern for acuity or complexity. So the provider thought that the fever's too high, or that some abdominal pain, or some other situation that they felt the patient should come in. There were some the response time was too long, just 5%. That was sort of a glitch as we got started. Most of these e-visits, from the time the patient finishes it to the time the physician finishes it, is about 60 minutes. That's the median time. And but some of these went 14 hours. That was initial when we had some snags just starting, and then some were not documented. When we look at the unresolved e-visits, sort of the characteristics of those, both in some chi-square analysis and logistic regression, see that men had higher percentage of unresolved e-visits. Women had about half of what men had. And then the older age group had a higher percentage of unresolved e-visits, 14%. It's about a third of that for the other two age groups. And then those who had presented with the conditions of diarrhea and skin issues had higher percentages of unresolved e-visits. Then we also wanted to look at those that were completed, the 1,400 or so that we were able to complete in the time period, and to say, did those folks have some sort of follow-up in the 14 days afterwards? And you see about 10% of them did have some follow-up. And then we looked at what type of follow-up that they had, and you can see that about 4% of them, a little over 4%, they had an office visit within the 2 weeks after the e-visit for the same complaint. And then we had another 4.5% were for email or telephone follow-up. That was usually just a situation of the medication didn't get sent to the right pharmacy, or I also had nausea, I forgot to tell you that, and I'd like something for that. And then we did have about 0.5% of repeat e-visits. When we look at those office visits, that 4.5% where there was a follow-up for the same complaint within 2 weeks of the e-visit, over 80% of them had no change in their diagnosis. Then when we also look at some of our patient survey results, we looked at satisfaction, and most people were quite satisfied with how likely are you to use the service again. Most of them, 93%, said definitely or probably will. And then was the e-visit able to address what was bothering you today? And about 94% of them said yes, they agreed or strongly agreed that it did address their issue. Now, going back to something earlier, Dr. Shah had presented that there appeared to be an increase in total visits in his study. We didn't measure that directly, but we did ask folks, if the e-visit had not been available, where would you have gone otherwise for care? And we see that half of them said they would have come to a doctor's office or the PCP. And then another 42% of them would have gone to an urgent care or a retail clinic or an ED, at least that's what they said. And then 9% of them said they would have gone nowhere, which maybe indicates that is some additional care that wouldn't have occurred. But we think, at least based on the survey results, we're not doing additional care, we're doing care instead of. So in conclusion, really older individuals were more likely to have unresolved visits. Asynchronous e-visit program showed some quality care. We had high patient satisfaction, limited need for follow-up for the same complaint, and low likelihood for change in the initial diagnosis when the follow-up occurred. And then we think that asynchronous e-visits may be utilized in place of office visits or urgent care ED visits. And we think this works well when the visits are focused on specific conditions within an institution, and we're using questions that are specific to the condition that they are presenting with. Thanks.
I like all the nuance, again, that telehealth is so many different things, and understanding the quality and outcomes associated with it requires digging much deeper. I have a few specific questions. I'll start, Lory, with you. You present the results as a savings to the system. That savings is because you're dealing with an integrated payer-provider model, and I just think for those who are less familiar with Intermountain or how that affects the way you think about this, it might be worth asking you to expand a little bit on how the savings here are kept within the system, whereas if the tertiary and the local hospital were not the same or the payer was not the same, how that would look different.
That's a really great question, and I made it sound so easy.
You did.
And obviously it has all the complexity that Alan's talking about. And I will even say within our organization, this becomes a challenge because, of course, now my life flight teams are not reimbursed. For those cases, they're not transferring. But I think really, ultimately, it is about doing what is right for the patients. And I think our organization, as an integrated healthcare system, has that vision. We're also moving toward an accountable care organization, and many of our patients, especially in the newborn population, are either our personal at-risk or Medicaid patients. So even though we internally are saving money, we recognize that this doesn't work for everybody, but I think the other point is whether it's newborn or critical care, we have very sick people who need these specialists. And if those beds are being taken up by a baby or a person that could be managed at their community rural hospital, we do have a net savings. And I have revenue, very high revenue, for those high-cost beds.
Great, thank you. Dana, this is maybe a slightly confusing question, but as I was listening, I thought about the challenges of thinking about cost savings for something like chest pain, where, as you noted, a very small number of people are actually going to have bad outcomes. And so when you're thinking about the difference between nurse and doctor, I'm thinking if you sent all these people home, you still would you'd probably save even more money, but that's probably not the right thing to do. So I just wonder if you could help me, and maybe others, maybe not, but at least me, think through how you understand appropriate levels of care for a condition. And you could, the consequences are much less dire, but you could apply it also to the acute respiratory, where where the frequency of severity is so low. How do you think about appropriate staffing for that? Does that question make any sense?
Yeah, I mean, I think it's challenging the vast volume of patients that come to the ER with chest pain, even though patients are scared about the condition and providers are scared about the condition. The vast majority of them don't go on to have bad outcomes, and I think that's the same thing with patients calling in with chest pain.
Yeah, I'm sorry. It's not a great question. It was just one of these things I was trying to get my head around.
Right. I mean, I think that the cost savings, potential cost savings, are just, obviously there is some sector of these patients who are going to do badly, and so and they can do very, very badly.
Right.
And so you definitely want someone, skilled and carefully evaluating their past medical history and recent cabbage or recent medication changes, and then being able to make a very safe, timely, careful recommendation of you are fine, you can actually follow up with your doctor in 2 days, or no, I'm actually worried and you should go to the ER. And maybe 80% of them who do go to the ER will be discharged home, but it's not. This is such a high risk condition. It's worth a careful evaluation.
And maybe since I gave you such a nasty question, let me ask us a less nasty one, which is, I assume as you're looking at the cost differential, the time spent for nurses, which is longer, that's not really what's driving it. It's the higher rate of saying, come on into the ED. That's really what affects. Okay.
Yep.
Thought I should at least ask you one question that it was reasonable to expect you to answer. Donglan, I was struck your title, and when you describe the paper, it's about super rural. But as you note in the findings, the increased use in TPA is actually greatest in urban settings. Mm-hmm. And you're talking about not a low frequency occurrence here. So I'm trying to understand why you would see such change in settings where you would think the volume would be large enough to support appropriate levels of care, even if you weren't in the most most sophisticated hospitals. So can you talk a little bit about the difference between rural, what the changes are in rural and in urban?
So we observe there's a much larger increase in urban settings if you expand telestroke care. Because this is, so first of all, TPA use is more prevalence in urban regions than in rural places, and because there's in some places there's TPA is not available, like in some rural hospitals, and even you have telestroke coverage, and you can accurately diagnose the patient if the patient is eligible for TPA use, but still, if the drug is not available there, it does not increase TPA use that much, and that's
that. Okay, yeah. So there's an availability differential as well. That's interesting. Kristin, I'm glad you noted that not only was there relatively guideline consistent antibiotic use, but it was pretty bad. So we can afford to improve it in all of these settings. But that very dramatic difference in strep testing, is this just a convenience issue that if I'm here, I can't go get a strep test, but if I'm in the doctor's office, I go downstairs? Or is there more to it? Do we think it's sort of an adherence convincing people? Is it that this resolves itself so you don't bother if you haven't? What do we know?
I think from the data themselves, we don't know. I think there is, a different flow of how someone might end up getting strep testing in a physician's office or an urgent care setting, where, as you mentioned, the test is kind of in the drawer and you can pull it out and use it. And so whether people are at the direct-to-consumer telemedicine visits are being advised to purchase a strep test and not doing it versus, they're making a clinical diagnosis and saying that it's not needed is unclear. With claims data, we don't know what doesn't hit the claims.
Okay, thank you. Marty, everything you describe with the data looks like a success. It looks like this is kind of what you would have hoped for. Were there places that either you'd like it to be better, or if it had been a little worse, it would deflate the enthusiasm? I'm just trying to figure out from a more evaluative perspective, what kind of results would you have either wished to be better or have been nervous if they'd been a little worse?
Well, I do think if the 2-week follow-up had been worse, we would be concerned about that if more people were having to come in. Now, I will say that the 2-week follow-up we looked within our own system. So if they went somewhere else, we don't know if they went to an ER or if they went to a retail clinic. So that's possible that happened. But I do think if we were having more follow-up, it might indicate that, yes, there's some testing we need to do that we aren't doing, a UA or a strep test or whatever. Yeah.
Okay. Questions from you all? I know it's been a long morning into the afternoon, but I want to make sure we ask what can be asked. So.
Hi, this is Claire Lin from HRSA. I have a question for Dr. Zhang. So I assume you use Medicare data, right? CMS Medicare. Did this go to the study at all that actually during this time period, a lot of rural area have hospital closed?
Yes.
So a lot of rural, you know what I'm saying, a lot of hospital closed in rural areas, and how would that affect your study, if at all?
Yes, thank you. This is a great question. Actually, we could not assess the impact of hospital closing on stroke care and telestroke use. But we, like in Georgia, in the year 2017, there's 3 rural hospitals closed. So, yeah, this is a big issue, and some hospitals they have trouble. They have financial issues. They continuously face financial pressure, and and in those situations, some hospitals just transition from like a rural hospital to acute access hospital, right? So and I think this do affect the expansion of telestroke care, because some hospitals just do not have the infrastructure to build up this technology. Yeah, thank you.
One more from the room, or we'll take one. Let's take one from the gentleman here, since Carolyn's had a shot at it.
Thank you. I'm Richard Canale with the compliance team. Question is for Dr. Player. I'm curious to learn when your patient satisfaction surveys were conducted. Was it prior to the 2-week follow-ups?
So immediately after the e-visit, they're sent a patient satisfaction survey, and then they're sent a second survey 2 weeks after. Does that answer?
Okay, thank you. And this is for the panel in general. I'd like to get some feedback on patient satisfaction in all of your studies and whether or not any were conducted, and if indeed that is a influencing or a reinforcement of the treatment and the patient's perceptions of whether or not they are being treated well.
I'll let you each weigh in.
So we did not specifically look at patient perceptions in this study, and it's kind of interesting because we don't ask people like, should we call in the specialist if there's an emergency? We do it. I will say I'm very fortunate in the demographics that I serve because they're 20, 30, 40-year-olds, and they expect it. So when I'm over there going, do you know how amazing this is? They're looking at me like, what's the big deal? You called in the doctor.
I would say we also didn't measure patient satisfaction directly, but I think the volume or the utilization, signifies that people at least appreciate having access to the service, and then the fact that 85% of people followed the recommendation. It's an indirect measure, but I think it's a valued service.
Yeah, we did not measure patient satisfaction in this study, but this will be our next step.
Similarly, our data did not include patient satisfaction. Similarly, there is increasing use, suggesting there's at least increasing interest. And there was recent work by a different research team looking at patient satisfaction during direct-to-consumer telemedicine visits and its association with antibiotic prescription, among other things.
Yeah, and obviously, there was high satisfaction, but these were people who chose to do the e-visit. These are direct consumer. I don't think it's surprising that they were so satisfied with it, but we are expanding it even to patients who are not MUSC patients. We have other platforms for that. And of course, we're graded on our patient satisfaction. Every quarter, I get a little card of how I'm doing on all sorts of things, and one of those is patient satisfaction. So I think this is another area that could increase that. Yeah.
Well, great. As we close out our day, I just want to again say thanks to the Leona M. and Harry B. Helmsley Charitable Trust. It's a major effort to pull this issue together and to hold this briefing, and we're thankful to them for their support. We had, at least when we started this morning, we had more than 300 people watching live, but we're also video taping, and this will be posted on our website shortly. So if you were here and you think other people would learn from it, please send them our way. Of course, please read the articles. The lasting impact of the issue is not just today, but the addition to the literature. And in that sense, I just want to close by saying what I said at the outset, which is that I feel very much that this compilation of research on a broad array of topics under the umbrella of telehealth moves our understanding of this topic forward quite substantially, and I'm grateful to the authors for their work. I think we know more about not just patient satisfaction, but quality and outcomes. We certainly know a lot more about people's access to services, and I think we saw some very interesting examples of implementation and potential for adoption that has not yet been realized, so this should help us set the course going forward. So as we finish up today, please join me in thanking our final panelists. And with that, thank you for joining us. We are adjourned.